back down to Shauna and end up with our guests.
Rob Smith, I'm the Community Partner and Tribal Liaison for Marketplace.
And I'm Joel Method. I'm the Communications Legislative Manager for Marketplace.
Hi, I'm Joe Enlett. I'm with the COPA Alliance National Network, and I'm also a policy analyst with the Multnomah County Health Department.
My name's Shannon Saldivar, and I'm an insurance agent from Medallion.
My name's Sean McAfee. I'm a certified practitioner for Texas Now, enrollment.
I'm Pat Allen. I'm the director of the Oregon Department of Consumer and Business Services.
I'm Clinton Case. I am the Training and Development at the Independent Primary Association. We work for all the federally qualified health clubs.
And I'm Ken Venture. I'm with Pacific Source.
I'm John Cormick with the Oregon Department of Justice.
I'm Laura Lawson. I'm a registered nurse.
Dan Field from Kaiser Permanente.
Barry Leslie. I'm the Marketplace Administrator.
Joe Finkbauer, Executive Director of North Area.
And as we have some people on the phone.
I'll stand up for myself. Good morning, everyone. Shauna Butler, Tomlin Benefit Planning on policy.
Jim Hauser, Hawthorne Auto Clinic, Portland, Oregon.
Thank you. Just one.
Good morning. This is Maria Vargas, Communications and Outreach Manager for Valley Family Healthcare, an FQHC, Federally Qualified Health Center.
And hi, this is Mark Fairbanks, the Chief Operating Officer and Chief Financial Officer for the Oregon Health Authority.
Mark and Jesse.
Yeah, hi everyone. This is Jesse O'Brien, Policy Director with OSPRD.
Okay, thank you so much for joining us on the phone. We hope you can hear us all right. Okay, with that.
Good morning. My name is Sandy Sampson, Confederated Tribes of the Umatilla Indian Reservation. I work for Yellow Hawk Tribal Health Center. And I have with me our Elder Chief Carl Sampson, our Legislative Committee on Indian Services for the state, Justin Quimps, our General Counsel Chairperson, Alan Crawford, and Aaron Ashley. They're all our board members that govern our tribe. So we're going to go ahead and do a prayer. So if you all stand up, please.
Oh, it's maybe Chuck Smisky. Me, my regular name is Carl Donald Sampson. My Indian name is Pio Pio Muxmus, which means yellowbird in our language. I want to first thank board members for coming to this gathering. I know so much of this is important for all of our people. We just lost one yesterday, an elder. And most of the time I've told people, in our way, I don't speak until maybe a year is up. I lost the younger brother about last July, and we're finally going to have a memorial to him this coming September. So we're kind of breaking my own rules and laws this way, but I appreciate this time. Kachaya pusha iya na mamima chifukla swa. Pia maklausa extended. Ask the Creator to bless everyone that's come this far to our home in the Cayuse, Umatilla, and Wallowa peoples. This has been our homeland for over 150 years. So with this, I hope you have a good week. I hope you travel safely here and reach your home. That's your
Thank you for the blessing and thank you for the welcome. And Sandra, we do have a few moments. We'd love to just, nothing formal, but just take some time to hear perhaps a brief report from you and your team about the tribe and the health status of the tribe. We're health insurance focused here, but one of the things we're trying to do is bring a statewide perspective to our work, and we know that the state doesn't consist of Portland. There is an Oregon beyond that, and it's important for us to understand some of the health challenges facing other parts of our state. And we'd love to hear your thoughts on that.
Every term we come with board priorities, and one of our priorities this year is allowing our tribal members a clear path to a fair life, a life of wellness, and just kind of providing an avenue for our tribal members to live healthy lives. And I think when we speak about those matters, communication is so important. So oftentimes tribes are looking for an avenue and a channel to communicate, and you being here on a reservation is moving forward towards that progression in communication. It's a two-way street, so communication is probably one of the most important things in relationships. And to me, when we're allowed to voice our concerns and the issues that we're having, it ultimately allows us to have a better relationship. And to me, relationships shouldn't be stagnant, but should keep growing organically, and this is part of that growth. So just want to thank you, but having you at the table allows us to understand the whole process a little bit better, just kind of communicating with Sandy and having a conversation this morning about Alan, just about what's happening, and we're learning as well as board members. So Sandy's kind of providing us with information that allows us to understand big picture stuff. So just want to thank you for allowing us to be here and be a part of this meeting. It does mean a lot in that relationship building.
I wonder if you could talk a little bit about what health means in the tribal community. You know, we're focused on health insurance, but health is obviously much broader than that. And has the tribe talked about that and what that means for your members?
Well, health, Alan Crawford, General Council Chair for the Umatilla Tribe. So health in our community, to me, and Tribal Council goes to our 12 Statute 945, our treaty. That's a big document. There's supposed to be many things, government to government, guaranteed to the people of this land by the United States government. Then we have a constitution and bylaws that we go by, as you do, and you call yours policies and procedures, you know, your bylaws of your commission or whatever you have. But to back that up, you know, as tribal council, we have to make sure that all of these pieces fit and that our people get what they're supposed to be entitled to through the federal government, and the state is here to help. Also, you know, all of the things that are out there in the world, you know, they don't discriminate. Cancers, the evil spirits of the man-made things, the meth, the drugs, you know, they don't discriminate. They'll take you. They'll take anybody. We've lost many people through many different ailments. Sometimes you say, well, we buried that person. That person had lymphoma. Did you bury the lymphoma? No. Where does it go? Does it just float around in our bodies till one day it wakes up and says, oh, today it's your turn to have this form of whatever, you know? I don't know. I went through that as a lot of people. But those are things, you know, that we think about all the time. And like I said, those are the documents we go by. And politics, as you know, to say, you're going to get this, you're going to get that, and then maybe sometimes it doesn't happen, or there's a barrier. And that's what I look at this format right here. It's a barrier that's coming down. And it's really good to see people here to help these barriers come down for, you know, the health, welfare, wellness of everybody. Okay, thank you.
Go ahead. I'll go.
Okay. guess what I can just add to that is health, I guess, is just a big deal, more so not just about our own physical health, as well. And around here, we also like to always say about spirituality, mentally, spiritually. I guess it kind of boils down to us being as strong as we can be as individuals for the overall health of the tribe. So, I was told at a young age, and it's been reiterated over and over throughout my years growing up. And even by my elder right down here, he took me under his wing years back and helped me out to the point where I understood that I had to be healthy, to be a provider, a teacher, a mentor, a father. And there's so many people older than me and younger than me that are dependent on me being healthy and strong back. So going on with this health insurance, it's important that I guess we have it, we are insured, because really you never know. You never know when your time comes. And those people that were dependent on you can no longer depend on you. So it's something that I pass on, not only to my children, but the folks that I just have day-to-day encounter with that we need to remind ourselves about daily. Even though I'm having a donut every once in a while, whatever, I still try to be as active as I can. I'm kind of slipping on, really, quite honestly. But I try my best, and we all can really do our best. Nobody's perfect. We all have our flaws. I guess just to end, health in just the sense of the word is very important. Given our history with diabetes, like how I'm saying cancers and such, and things that all communities are faced with. But yeah, health is a huge issue. Like Justin was saying, it's one of our priorities on our priorities.
Thank you. Sandy?
I started on the Cover Oregon back in 2011, so my perspective is a bit different than probably a lot of people's. When we were working as a technical work group on Cover Oregon, it had its flaws. Personally, the marketplace, I guess as a tribal perspective, the Indian addendum for insurance is really important. I think we spoke with Barry about this, and making sure that because we're a sovereign nation, there's a little bit of different perspective as far as how, say I'm working at the clinic and I'm a nurse practitioner. Well, my license is in the state of New Mexico, but under the federal government, what is it called?
Reciprocity.
Huh?
For licensing reciprocity?
Yeah, but I mean for them to be covered. So, for
for insurance.
Yeah.
For federal tort claims.
Yeah, the federal tort claims comes in play. So, a lot of times insurance agencies don't look at that as the coverage, but the federal government does. The United States government looks at that as them being insured. So, since 2011, we've been working with the state of Oregon when it was Cover Oregon. And some insurance agencies they don't want to deal with it. We work with Eastern Oregon CCO, so we've worked out the addendum both for Medicaid and Medicare. We use Family Care for Medicare. But on the shop or the marketplace, it's been significantly, we haven't wanted to do an agreement with MODA because of some of these issues that may arise. So I think Oregon really needs to look at that. You have 9 tribes. There's a lot, you know, Klamath Falls is probably the only one that has signed a contract. I believe it was with Florida. But we have our economics for a lot of our tribal members, whether they're urban or they live
the brief that I made. So some of this may be review for some of the people at this table, but as I said, I wanted to make sure that we all were on the same page. So Indian Health Services is a federal agency that provides funding for tribal clinics, and that funding is somewhat limited. So those clinics receive a certain amount of funds throughout the year. So usually, tribal members and their families can go to the clinics depending on the clinic's policy, and they can receive free health care at no cost, obviously, for whatever they need. However, some of those clinics don't have all of the services that may be necessary for that family. So with the Affordable Care Act, tribal members are also required to have minimum essential coverage, and that health care that they receive through those clinics is not considered minimum essential coverage. So they will actually have to do the exemption. So they actually do have to fill out the exemption for that. If they qualify for Medicaid, they can sign up for Medicaid and receive those services, and they are always able to purchase a marketplace plan if they wish. So some of the benefits that they receive when they purchase a marketplace plan, they can receive zero cost share and zero out-of-pocket costs. Or zero cost share means zero out-of-pocket costs and zero any out-of-pocket costs that they have to pay. They don't have to worry about it. They also can, if their family is below 300% of the federal poverty level, they can receive a referral to any clinic outside of their Indian Healthcare Services clinic, and they don't have to pay anything out of pocket for them as well. If the tribe participates in the Tribal Premium Sponsorship Program, that means that the tribe can actually pay for the premium costs for that tribal member. And so that tribal member will not only have no out-of-pocket costs, they'll have no monthly premium costs as well. So really they receive completely free health care. The benefit of that for the tribe is that now that tribe can actually build insurance carriers for those services. So that small amount of money that relatively small amount of money that I was talking about with the tribal clinics through IHS, those dollars can now be spread, or they can be used more widely because now the benefits are being billed to the carriers rather than to the clinic itself.
Rob, is it your experience, and maybe ask Sandy as well,
Sure.
is it your experience that that's working well with the traditional carriers being billed? And
in my conversations with Klamath, they said that they have had a few hiccups. There was a lot of initial, they did have a contract with MODA. There was a lot of initial discussion, a lot of negotiation that had to be worked out, and there were some billing issues. But we were able to work with, so we have a carrier liaison on the team as well. So between himself and myself and working with the tribe, we were able to get those issues worked out fairly quickly. And that's one of the benefits of having our local team is that responsiveness, and that we're able to respond to any issues that might come up with the tribe. So if they have an issue, they can contact us right away. Does that answer your question?
It does.
I think the tribal premium sponsorship, there was a contract that, and I actually have copies of Rob, that when it was covered Oregon, Sansray Cornell, she was the tribal representative at the time for Cover Oregon. And to have that agreement and making sure that insurance agencies, whichever one that the tribe that decides to utilize, the Cow Creek people, the tribe there, they were having some trouble in regards to, because they insured everybody, they weren't able to use the tribal premium sponsor, and Rob can give you more information on that, and it was kind of a barrier. They didn't, the insurance marketplace for that region, and I don't remember what insurance carrier it was.
Atrium.
Yeah, Atrium, yeah. So, I mean, there's some flaws. They want to utilize it because they want to pay insurance for a lot of their tribal members that live in, the urban area. So, to make it more feasible for tribes, I think it's imperative that you look at when you negotiate with carriers that they understand the liability of insurance.
And I wanted to mention too that Klamath was with MODA. They just recently moved to the Atrium, and so we, between myself and the agent liaison and the carrier liaison, we did a lot of work of finding an agent that would help the tribe move make that transition because it's not an insignificant amount of people, and it actually went smoothly there with Atrio now. But we had to start those initial conversations with Atrio and really provide a lot of education for them because they had a lot of questions that were just kind of off the wall, obviously because they want to make sure that they're protected as well. But it was just really having those conversations initially, and Klamath reported the last time I spoke to them, which was last week, that everything's going smoothly. So I think it's really important. And I wanted to mention that the TPSP for Klamath, I think they estimated that they spent about $9,000 over the course of the year for the members that they had enrolled. And if you think about the health costs for those people, they're actually now able to bill to insurance. So they're saving quite a bit of money for their tribal clinics. So really, over the course of the next year, Klamath is going to present at a health cluster meeting later this month, and really just spend time providing information to the rest of the tribes about this program. Because I think there was, like Sandy mentioned, there's a lot of initial trepidation of getting involved with this program because it's a scary new system. But we're really trying to get the education out there because we feel that the benefit of the marketplace for tribal members is really inherent in this program because the clinics receive the benefit of additional funding, or at least their funding can stretch out a little bit longer. The tribal members can now go receive specialty care that might not be available at the clinic. So really it adds to the overall health of the community. I think that's about all I have. I mean, it was mentioned that tribal members can enroll at any time in the year. They can also switch plans at least once a month. So if they're not happy with their plan, they can switch to a new plan. And I would like to get this presentation that Klamath is going to do for the health cluster out to the committee here. I'll send that electronically. I just didn't want to print too much, trying to save some trees. Yeah. Any questions?
If I could just make a comment, Rod mentioned that this was done from a piece that he did for me, which was in turn in response to some legislator inquiry that I was getting. And this is, as you can see, it's not super complicated, but it's not a sort of a simple, straightforward one piece takes care of everything. And this was at a time where I was getting a fair amount of input from legislators saying, well, I thought Native Americans were just covered. And so helping policymakers understand that it's actually a complex web of different kinds of ways to get access to services and providers of those services and insurers is an important part of what we, as the marketplace of the department, need to help overcome some of that lack of understanding of the system.
I hear the important, oh, sorry, go ahead, please. I was just going to say, I hear the important conversation is between the tribe and the carriers, but also it sounded like there's a need for a lot of communication out to agents and assisters who are working on this. Do we have some specific strategies for that to make sure that everybody in the state has access to this level of information?
Sure. So my counterpart, Michael Mortar, who's the agent liaison for the marketplace, and I work very closely together. We're kind of like the outreach team. And our specific strategy is just our constant communication between each other. One of the things that we're thinking about for this year, when we have our agent storefront program and our community partner program up and running, which should be sometime in July, is to get agents and community partners together in a room and talk with them about making partnerships happen. In addition, we want to provide trainings throughout the year, maybe every quarter, on different subjects. The first quarter I think we're working on right now is training on people living with HIV and with Hep C, but eventually we want to try and get through all of the sort of specialty groups that people might have special considerations when they're enrolling in the marketplace, and I definitely want the tribal perspective to be a part of that, and so I'll probably work with Sandy and other tribal clinic leaders to provide that training to make sure that everyone understands.
I was going to say our CCOs include Warm Springs, and that's just on the Medicaid side, but it does get complicated. The interface with IHS and everything creates there's a lot of need to get aligned and thinking for us to understand things and so forth.
Yeah, I think fundamentally our job is to make sure that that complexity gets dealt with by carriers and providers and agents, and not putting all of that, sorting everything out onto individual tribal members or other insurers. It's complicated for us to figure out. Do it every day.
Tribal members will walk away if they're the ones that have to clarify all of that information.
And I think Sandy sort of touched on, you get in your little box the way you think about things and you're thinking about requirements. I think one of the things that Sandy was referring to is the whole issue around credentialing, which you don't want to get me started on, but creates some issues because we're used to working within these rules over here and they're different.
Right. Yeah, it's really complex.
One of the things I always do is shake hands. I was taught that by my parents. You gotta go quick.
Thank you for coming.
I'm glad you met me.
But I think collaboration is really important, and when we did start when we started working with insurance agents back in 2012, we brought them all in one room and we all met. So I think it was so fast when Cover Oregon actually introduced the marketplace and how complex it was and making sure everything was aligned in their portal system. I think you have to be very cautious of how that's implemented because you've got a lot of mixed families too. You've got tribal members, non-tribal members, all in. You've got kids of tribal members and not enrolled, and so that whole complexity of that family unit is important. Well, it's important for everybody. So
I think this speaks to also the need for us to be very targeted in our outreach efforts when we're doing trainings, that it's trainings that incorporate specialized knowledge because it addresses the diversity of our communities. I think each community has also diverse needs and unique needs that we just can't do a whole blanket outreach strategy and expect that everybody will become healthier and well. I guess it's kind of revealing my bent on what we're going to be talking about later on, but I think a strategy that really incorporates the different and unique aspects of every community that we serve. So
we have all corners of the state represented here. Laura and Sean, I want to make sure you have a chance to talk about some of what we heard about resonates with the tribal members that you're working with in Curry County or in county or places.
So I'm very grateful to also be able to have a chance to hear from you, Sandy. And we have some tribal members enrolled through my agency. And we could do a better outreach job. I recognize that. So thank you.
Okay. Sandy, you're certainly welcome to stay. We want to thank you again for bringing the tribal leaders, of course, for you showing up here on a Monday morning and really helping. I know this is educational for me. I know some people may have worked with you, Barry and Rob and others, but for me, probably some other committee members, this is a bit of a learning curve, so thank you for sharing that.
Well, thank you for having your meeting here. We appreciate coming and being able to share our thoughts and of our wisdom of the marketplace and insurance in general. So thank you.
Appreciate that.
I know what you're going at.
You did kind of wonder, didn't you?
Yeah.
So much.
Thank you for having us. Rob, Joe, Alan.
Okay, with that, Barry, let's segue. We'll keep on moving here. We have some big chunks later in the agenda. We're saving the complicated stuff for last. But let's go to some updates.
Just easy topics today, right? Nothing to see here. So just a couple of quick updates and a little refresher from last time. We spoke last time about how the health insurance marketplace will have subcommittees that will work in partnership with the marketplace. That'll probably be members from this committee and members from other stakeholder groups that want to participate in discussions on key issues. And so 2 of the subcommittees that have been formed, and some of the folks in this group have been and will be working on them, are the Compact of Free Association Work Group, which is implementing the House bill that creates the premium subsidization program for COFA members. And the other subcommittee is the Basic Health Plan Subcommittee that was charged last time with going forward and creating that kind of subcommittee infrastructure. And primarily, the first task is to bring back some really comprehensive analysis about what a basic health plan could look like in Oregon. So I really just wanted to give you folks a status report about how both of those subcommittees have been working, and also just remind you that if ever you want really specific details or the documents or all of the good stuff associated with all their meetings, we have on our website for the advisory committee also a COFA advisory committee website or subcommittee site and a basic health plan site. So if there's ever like, gosh, I just really want to go out and read more documents, Barry doesn't send me enough, we have all of that online too so that you can look at. But the high level update is that the COFA advisory committee met on April 12th and formally adopted the committee charter. It was a terrific meeting. Both Joel and I attended, and some folks in this room, so Sean and others, Joe, please feel free to chime in if there are things that you think are salient that I'm forgetting. We have about 21 members on that subcommittee, and it's folks from the legislature, the Oregon Health Authority, COFA communities, agents, and community partners. The next committee meeting will be on May 25th, and at that meeting they're going to get into outreach and education, an actual overview of the premium payment workflow with the carriers, and an out-of-pocket payment model between DCBS and program enrollees. So that's going to be a pretty substantive meeting, and I think committee members actually already even have their materials because there's a lot to wade through. So anything, Sean or Joe, anything I'm missing there that might be helpful for the group?
Pretty solid overview.
Yeah, I think the main focus for the committee right now is really the outreach efforts. The complexity of having to sign up, and then with OHA, get the denial letter, then sign up for the marketplace, federal marketplace, then sign up for the premium assistance program. And so we're trying to figure out what's the best strategy forward with the community. So that's where kind of the discussion is really at. There's a subcommittee of the big committee that's talking about that. So I'm on this committee, and then that committee, and then the subcommittee for outreach and enrollment. But I think it's good. It's very helpful. A lot of people, we're working really closely with the OHA folks, which I think is very key to this, and streamlining our efforts, which I think would be very helpful even for us on the larger marketplace to really have that streamlined effort from all levels of government, including our partners.
Actually, an interesting point about that, Joe. We just constantly see opportunities where OHA and we could be working better together. And recently, and Mr. Fairbanks, I'm not sure if they're back online. He and some of his colleagues were helpful in trying to determine whether or not they could get information about the marketplace.
Yeah.
They put in just their regular communications with folks in denial letters or folks who are now eligible for Medicare, just to make sure that there's kind of the seamless communication between us. There's so many opportunities for that.
Yeah, and as an FYI too, what we're doing here in the state, there's a lot of other groups in different states that are really looking at how we're dealing with the COFA issue, which is a national conversation right now. And there was a meeting conference that just happened in Oklahoma. There's one coming up in Arkansas, and 300 people from the community came out. They came to the legislature. We have legislatures who are calling us and saying, "Hey, what are you guys doing in Oregon?" We're like, "Okay, hold on, because we're trying to figure it out."
Oh my God, we're ahead.
Yeah, I know. They're like, "What? You had bipartisan support in this?" And they're like, "Yep, that's what we did." But yeah, just so we're gaining a lot of national attention with the work that we're doing. So.
No pressure, Chicky, right?
Yeah.
And so the other subcommittee, the Basic Health Program, that's really kind of an interesting subcommittee. They have not met yet, and the reason for that is that Wakely has to do a pretty complex analysis first in order for the subcommittee to really have something to talk about. And so they're in the midst of that analysis in terms of not only what the basic health plan would look like in Oregon, but also some kind of other economic musings to figure out if there are some alternatives in terms of qualified health plan benefits and cost sharing and eligibility determinations that could be other options for the subcommittee to look at. So that's supposed to be done at the end of June, and then the subcommittee is going to actually meet the week of July 11th through 15th. So there'll probably be a lot more significant updates this summer in terms of specific conversations that's happening. I think that's it for unless there are other questions or updates.
I want to just pause here because I want to make sure that, this is important work. We asked it to be sent to a subcommittee. That doesn't mean it goes away and never comes back. It's important work that's happening. I'll make sure the full committee is staying engaged, and we're really fortunate to have some people involved on these. But I want to make sure we're very conscientious about having the full committee have a moment to ask questions, because it'll start to pick up steam. Then of course it'll come back to the full committee for review and approval. But appreciate it. So Jesse, the co-chair, and I, vice chair, and I asked Barry to put this as a standing agenda item, so every meeting will have some updates from the subcommittees. But if you're not getting the information that you need, let us know. But thank you. I thought that was spot on. That's helpful. And we realize they're just getting rolling. So.
They are, and there's just going to be lots more updates.
Yeah.
Pretty meaty, weighty things for y'all to look at. So.
Good. Okay, people ready? Any comments on the phone? Questions on the phone? Hopefully you're able to hear most of this okay. So Joel, let's segue to the marketplace communication. We're already looking forward to next year, believe it or not.
Yes.
Hopefully everybody got, take a month off or something before we start.
Joel was like, do you think March would be a good time to take vacation? And in March, I turned to him and said, oh, sorry.
I'm getting a vacation soon because one of my family died. That's the reason I So hello everybody. If you didn't hear at the beginning, I'm Joel Mattman. I handle communications for the marketplace. And what we're going to be talking about today is outreach and education. And we use that phrase to describe a wide variety of things that we do. We're going to specifically be talking about our efforts during open enrollment, so a very small portion of the year. We also do outreach and education throughout the year, and that's primarily what our staff at DCBS is dedicated to. So like we have Rob here, who's dedicated to community partners and fostering that relationship with OHA, and he works with the tribes to perform outreach to make sure that they have a voice in everything that we're doing. We also have Michael Mortar, who has two roles. He does outreach to agents and does a similar role to what Rob does with community partners, and he does outreach to small businesses because that's an important component. We're not just for a marketplace for the individuals. There's the small business component. We also have an entire team of outreach coordinators who were formerly, the position in Cover Oregon was as a call center representative. We changed that a little bit when we moved to DCBS. These folks now have a split role. They have some call center duties, but they're also out in the field, and they're assigned regions throughout the state where they have to be involved in the community. And right now we're developing the kind of year-round plans for their role and what they need to be doing and who they need to be reaching, so that we're not right for open enrollment trying to make relationships and try to get the word out. You have to build these networks throughout the year. There's important information you need to get out throughout the year with life changes. We're not talking about a static pool of people that fit into the marketplace coverage. There's churn from different types of coverage. People lose their job, people make more money and get off of Medicaid. So there's a constant need for ongoing education, and there's always the opportunity for anybody to sign up. Tribal members can switch once a month. There's this need that often gets overlooked when we talk specifically about open enrollment, because that's the big rush, right? That's, hey, this is your chance, quick, you have to get enrolled if you want this coverage, or else you could go without it for the rest of the year. So we're not going to be talking about the year-round stuff. We'll talk about a little bit, but mostly we're going to be talking about specifically open enrollment today. if you guys have questions about or year-round stuff, we're happy to come back. And you can even have Misty come because she leads our little work group every single week where we talk about what we need to be doing and what we are doing. And that's a fun group. So I thought we can't really talk about next year without talking about last year, because all of our plans for next year are based on lessons learned and input from our partners and agents and consumers about what we did this last year. So I'm going to quickly talk about our 2016 open enrollment campaign. So open enrollment, as you know, was from November 1 to January 31. And this was the first year for DCBS to do a outreach and education campaign, because the marketplace moved over to DCBS in July, and we had, between then and open enrollment, put together a campaign, base it off as much as research as we could from what Oregon did, what other states were doing, and try to come up with something that we thought would satisfy those overseeing what we were doing, including the legislature, who was pretty doubtful about the state's ability to market and to do outreach in an effective, cost-effective, and effective manner.
No guitars was the specific.
I was just thinking about guitars. Yeah. We cannot use humor in our campaigns. So when we started this out, we had 3 real goals, because we weren't sure exactly what it was going to look like and what the results were going to be. One of the main things is we did not want to lose our market share, especially amongst the subsidy-eligible people. We didn't know what was going to happen between switching from Cover Oregon to DCBS, if there's going to be something lost in the transition. And we still weren't sure what the full market share would look like for the marketplace, and that's a number that we're looking at as we continue to go. What's that point where you penetrate and you just can't get any more people? So the first year we didn't want to set a goal and say, oh, we're going to enroll 50% more or something, because we didn't really have an idea what was a realistic percentage increase. So we really just wanted to make sure that we maintained our current market share, and those people that were still eligible at least have the opportunity to know that they can have the choice of staying on, and this is how you stay on, etc. So the other important thing for us, the second goal, was really talking about making sure that people actively shop. So you had the option for the first time to automatically re-enroll, but that might not be in your best interest, right? Because plans change every year. What they cover, what they cost, they may no longer exist anymore, and you may be moved to a different plan. So we wanted to make sure that people had an active role in that process. We had to make sure people knew about that. And then we wanted to figure out what's a reasonable percentage of people that actively shop, so that we can kind of set a benchmark for future years. Because again, this is one of our goals, is that people actively shop, because they do save money. I think it was between $40 to $44 per month nationally in savings for people when they switch plans. And sometimes that was just switching plans within the same metal tier. Sometimes that was switching plans between carriers. The net result was you can save money and still get the same level of coverage. There's choices out there, and we want to make sure people are looking. And then the third was that the state had taken a real hit, and the marketplace in general had taken a hit from previous years in terms of credibility and trust. And we wanted to start to build our credibility as DCBS and the marketplace's credibility as a trusted resource for people. So this is kind of the third goal that, it's what we're trying to do with our outreach and education, is build trust so that people will come to us for information, and then we, in turn, try to respect that and provide truthful, helpful, actionable information. So these were the defining goals for us, and really guided every decision we made. Yes?
Before you go off of that, and I know we're going to talk about the age cohorts later, but at this, the highest level, your 3 really high-level goals, I wonder if you talked about actually putting in your goals driving increased enrollment among that lower cohort, 18 to, what are we classifying, to 34, but
right.
You know who I'm referring to?
I do. Right.
Does that deserve to be at this high level, even though I know later in the presentation we talked about that? But if we're tracking those percentages and we believe that the marketplace success relies on a balanced risk pool, shouldn't one of our campaign goals be to drive those numbers to where we want to get eventually?
Right. So last year we did not include age-specific goals or even really targeting, because again we were testing the waters in terms of our own ability to do marketing and outreach. And that is important to us, and we realized it more and more through last year's open enrollment campaign. So one of the changes this year is we are doing more specific, kind of like a sub-campaign for specific groups that we feel that were not well represented in our outreach efforts last year. In terms of hierarchy of goals, so above this one level, if you take a step back and you go to our overall communication goals, so this plan is a sub-plan of our communication plan, which has to do not just with outreach and education, but stakeholder engagement and working with as many different organizations that we touch upon as possible. And the real goal there is to drive enrollment, period. And so we have that higher goal, and it's not just enrollment in the marketplace, it's to make sure that Oregonians have the coverage that they need, whatever that type of coverage is. So we start from there, move down to here where we're talking specifically about marketplace goals, right? This is the marketplace we want to drive enrollment. For next year, I'll have to figure out how to put it in there, because I think that our utmost goal has to be making sure everybody gets the coverage they need, but it is actually one of our goals to reach that specific age group that you talked about, because we do recognize that we have a lopsided marketplace right now where you're overrepresented in the older age groups and underrepresented in the younger ones. And there's many reasons for that. And we're actually going to be doing a ton of research. I'll talk about it when we get to 2017. We're going to spend a couple of months doing research into the younger adult population to try to figure out where they are, what kind of messaging works best with them, how to reach them, and from that, I expect that we'll have a number of takeaways that we can turn into goals specifically to be realistic about it. I don't want to go like this year. We were very careful about last year. Last year we were very careful about not setting a goal without understanding the lay of the land. And so I think once we get back at our research, and I'd love to be able to circulate what we find here, and my intention is to circulate actually with other states as well, so maybe we can help them. We're spending a lot of time and money and effort on this research to figure out exactly what is realistic, right? We may find that it's going to be, nationally it's been extremely difficult for people to reach this audience. And so we'll see what the research says and what we think is a realistic goal.
So we had tremendous success this year, and we've been really proud of that, and it's appropriate, but let's set the goal higher and let's really target the millennials, because we know that long-term our success depends on that. So I just creating more visibility. I know it's not like I'm telling you something new. I know we're focused on that, but I'm just encouraging us to hold ourselves accountable by moving it into some high-level goals, so that we all know at the end of the year what we're going to really look at is, are we creating a stable risk pool that allows the marketplace to succeed for many years? And so it's just a matter of nuance. I think you're less likely to lose that focus if it's brought up as high-level goals. But I know we're not reviewing next year's goals right now, but
right. No, we completely agree with you. And when we get into 2017, I'll talk a little bit about different market segments and how we're planning to approach them. All right. So with all of this in mind, last year, again, these were our main focuses. We wanted to do outreach to everyone who's eligible for QHP, and then specifically look at those who are eligible for subsidies, because they get a ton of value out of the marketplace, and we want to make sure that everyone within that eligible population knew about the opportunity. We took a look at the distribution of eligibility across the state, and we identified 11 counties where there was still a significant percentage of the population that was QHP or subsidy eligible and weren't enrolling. So we wanted to do some more targeted research, do extra ads, do extra in-the-field outreach. And then the third was to make sure that it wasn't just a blanket marketing campaign, that we really took into account that you have many cultures here in the state, and that you're reaching them through the channels that they trust, with messaging that's appropriate, and providing them with access as is needed for their specific circumstances. So these are the messages that we focused on last year. You know, making sure people knew it's open enrollment. One of our most touted one was making sure people knew that there was free help. We did that for a number of reasons. All this stuff was based on research that we did and consumer surveys and reaching out to people. We wanted to make sure that people knew that there were agents and community partners and others available, because it really helps them have an expert by their side, but also it's also going to help ensure retention. Agents will call somebody back the next year and say, hey, here's a reminder, here's open enrollment's coming around again. And have that touch point, to have somebody there that's to advocate for them and to help them. The deadline one, which is we've seen it both here and nationally, that this is one of the biggest drivers in terms of getting people covered. It's messaging about the deadline. Shopping every year, like I mentioned before, the financial help through subsidies, finding the right plan for you and your budget, and then one that we started halfway through open enrollment was really focusing on COBRA messaging. We found that there wasn't a lot of information out there. Employers weren't providing information about the fact that people have a choice when they lose their other coverage to go with marketplace coverage instead of COBRA, and in many cases the marketplace coverage will be cheaper and you might get a subsidy out of it. So we wanted to make sure that we started doing that messaging, and that actually ended up being another one that had... Yeah, go ahead.
I didn't mean to interrupt you, but I wanted to hang on before you switch. So I want to ask, look around at all the S's, Sean, Shannon, Shauna, anybody that's doing enrolling and working with individuals. I'm just wondering, as you look at these, did all of those come through? Were some stronger than others? What advice do you have for marketplace staff as you're reflecting on your experience? And anybody's welcome, but I was just thinking of those people who are working with members.
I think they get free help. I mean, I worked with, I was one of the storefront agents, which was great, so I got to give my feedback at the wrap-up. But I think driving them to local help is really important. I think customers are most satisfied when they can sit down with somebody face-to-face and get the information and have somebody to kind of support them through the process. And I think ECBS did a great job. It was wonderful to have support as an agent. Plan year 15, we were all by ourselves. So you guys did a great job connecting and engaging with us, and I think engaging with the consumers too. So I know we were really appreciative and thought all of the messages were helpful, you know. Definitely local. I mean, focusing on local help was really important to me as a local insurance agent. So.
Yeah, second all of those points, especially direct people help. At least Kaiser Family Foundation's numbers said about half of people had some form of assistance from a community partner or agent or something. They at least asked questions from some live person before getting onto the marketplace themselves. So that's about half the population needs some form of assistance, and directing them to that is very important. You're also getting a lot of those messages covered by outside, like insurance carriers and other people trying to get some of their clients as well. So it's not just from the state that I was hearing it frequently from outside sources as well.
So there's an echo chamber effect, which is a good one. Yeah, that's helpful to remember.
And for me, it would be the same thing. Getting help from a local expert, I find even now, well after open enrollment, and Shannon and I were talking about this, and this is probably for you as well, Sean, and that is that we're doing so much problem solving that the people who didn't use an agent or somebody that could advocate for them, for example, in that COBRA, they don't know that they are not required to take COBRA. You know, sometimes I can catch them before they enroll in the COBRA, but there is a disqualifier or a knockout question through the marketplace that says, you know, are you eligible for COBRA? It doesn't say, do you want to choose the COBRA? It just says, are you eligible or not? And I had to learn the workaround early on because a lot of people are eligible for COBRA, but is it most appropriate for them to choose COBRA? So that becomes the question. So again, having local help, having somebody that will be willing to advocate and for months follow up with your clients, and to be able to guide them with regard to their choices, their options.
Thank you all. Yeah, Claire.
I was just curious if the tax penalty piece has come into this at all. I mean, is that within the deadline or?
Yeah. So you'll notice it's not up there, right? So we included the penalty messaging whenever we include something that's longer than a single line, right? So you can say, hey, the deadline is coming up, avoid the penalty. We didn't do messaging that was just the penalty. I was a little hesitant about doing that, especially since with the history of Cover Oregon, you know, just going out there, starting with the message that you're going to be penalized. We wanted to be as positive as possible, right? Look at the benefits of being covered. That said, we have seen CMS and other states have had success with the younger crowd with the penalty messaging. So we will be adding that. That will be one of the things in 2017 we will be adding.
And I had quite a few consumers during open enrollment come based on that, avoid the penalty, right? But then we're not happy when they filed their taxes, as Ed assumed. Well, I got it, so now I don't have to pay the penalty, not realizing it's for the next tax year. So that was really just kind of confusing, right. You know. So
and it's confusing because we'll often talk about avoid the penalty for next year, and it'll be a different amount, right?
Right.
Previous year, it's not. Yeah.
Right.
Joel, ironically, I think one of the difficult groups to reach, which will be really critical in 17, is people that have to do something. Their plan is not available.
Yeah.
And I know that our notices don't seem to motivate that very well.
Yeah.
That's a group in 17. There's going to be a lot of folks, you know, likewise, and going back, and I mean, there's a bunch of us that are doing different things.
Right.
Reaching that group so that they really understand you have to get activated. You need to do something.
Right.
Will be really critical. We'll have a bunch of folks floating around at the end of open enrollment with no coverage.
Right, and I think that if we can work with insurers on that messaging so that people understand it's not you're just not left at the wind there, and especially getting them to the local health so that they can understand the implications and that you know every plan is going to be different, and it would be really helpful to know exactly, especially because if you're changing your coverage in the area, being able to keep your providers and continue the continuity of care, you really have to make the change. I think is going to be a interesting thing for us to figure out how to message at the state level, but then it's going to be a lot easier through the local contacts, right? So they can understand the individual situation, because that's the problem we find with, you know, again, I'm talking about outreach as the whole package. So at our level in our office, we're doing marketing that's trying to reach people even on an individual level with individual targeted ads, but then you have folks that are out there and trying to provide it more on that individual level for people's exact situation through our agents and community partners, and through even our outreach team who goes to events all over the state. So it's going to be a multi-pronged approach to try to deal with that.
I talked to Maria a couple of weeks ago, and I don't know if she's still on the line, but of course she's in Eastern Oregon, and she was reminding me that her two plan options, or at least two of them, were in Eastern Oregon, Remota and LifeWise, both of which are pulling out. So if you think of, you know, a whole big section of Eastern Oregon that Maria's representing, all of those people are going to have some major changes, as you point out. Not going to be able to keep their doctor, and hopefully at the point of care it doesn't feel very different, but they got to do something or they're going to have problems if they don't get that transition made.
I was just looking at numbers for Central Oregon, which is one of the markets that we will still be in. I think there are about 60,000 people that are currently in the marketplace, and over 12,000 of those are going to have to make these selections to LifeWise, and we contribute to that and other counties. But it'll be a lot of folks that will fall into that area. That category have to make the elections.
So a comment from Cindy and then Shannon, and then that's a nice segue into 2017 tactics. But Cindy, go ahead.
I think this is great. I think we have a real challenge because I have two children who are in this millennial group, and for the third year I'll be looking for a new plan on the marketplace or in the marketplace. And I think the financial piece is such a huge component, whether it's a penalty, what the subsidy is, what the premium is, and there's a piece that I'm not sure how you can speak to when you talk about cost savings that people have saved $44 or whatever it is that only on the premium piece? Because on the backside, I have one of my children who's appalled at what he pays in insurance and then receives no benefit on the front side because he self-insures. And so I think once you have that experience, it's a tough sell if you can't afford it.
Right.
I mean,
no, I mean, that is one of the major concerns is that you can tell people that, hey, you only have to pay X amount per month, and then they're like, well, what am I getting for that X amount a month? And we saw that in stories throughout open enrollment throughout the last couple of years, and then even when we tried to quantify it with some actual survey data, we found that there are a lot of people out there who say, yes, I have the coverage, but I'm not satisfied with my coverage. And there's only so much that we can do in terms of, like, we're not determining what plans end up on the marketplace, but there were a lot of people that missed out on, like, that could have gotten cost share reductions to reduce the amount they pay each time to go to the doctor, how much their co-insurance were. And I think if many people saw the low premium, for the bronze plan, went for it, not realizing that they were giving up something by not taking the silver plan. It would cost a little more per month, but then it would cost less overall. And I know healthcare.gov's tools are getting better at allowing people to do that, but it's still hard for the individual to know even how to look at it. And I think that's where we get back to the local health issue, right? So that people can actually take a look at the individual circumstance and say, hey, in your circumstance, I would recommend a plan like this that has these benefits, right? So that they understand what their end cost is going to be, not just the premium cost.
Right. What I'm suggesting is, I think in today's environment, it's almost impossible to come up with the end cost, a realistic end cost, unless there is data that is my premium, when I pay my premium to the insurer, is that lower premium offset by a higher negotiated price with my provider? So in the end, I'm paying more. As a consumer, there's information that simply isn't there, and you'd have a tough sell for me this year, because that's what I'd go in and ask. Prove to me that my out-of-pocket expense is going to be less. So it's just, I think we've had, 2 years, I guess, with the marketplace plans, and people coming to the party of cost savings on the front end may not apply on the backside, but there's no place for me to find out what the backside cost is.
Let's see, if I had one thing I could do over again in the whole nationwide, it's the whole bronze, silver, and gold terminology that sort of charmingly sounds like Olympic medals, and they're all good. When really a bronze plan means you're signing up to pay almost half of your healthcare costs. It's a 40% plan on a bronze plan. I think long term there's somewhere to go with that, but as a national terminology, we've got to start with.
Well,
but getting people to understand that notion of bronze means half.
Well, and that's the question is not, I've done that because I'm relatively healthy, so that's fine with me that I know my ongoing expense. Right. But what I don't know is if the expense were all the same on the backside, if a procedure cost that I'm insured by LifeWise, I knew was $1,000 and that $1,000 was true for MOTA too, then I have the information. Yes. But MOTA's cost might be $2,000. My premium's lower. My premium's lower, but my cost share is much higher. So I think it's great to talk about this on the front end. I think experience is giving questions that.
Let's move to Shannon. I think you're raising an important issue that we'll come back to probably for several years. As Pat noted, I think that's really version 2.0 of the federal ACA, and what we'd love Congress to get to eventually is more standardization, more transparency around the bronze, silver, gold, around yeah, your point is really well made about, 40% of what, and the what is going to be different if it's LifeWise or Moda or whatever. So,
well, and I think it's an Oregon issue. It can be treated in Oregon. We don't have to wait for federal. If there is not a requirement, and as I understand it, there's a state law that prevents the sharing of prices.
Right.
Well, that can easily be or not easily be fixed, but could be fixed by legislation. And in my opinion, it's the marketplace's responsibility to bring that piece of information to the website to allow people to shop.
So that's a whole discussion around transparency. We'll ask Ken to come back and give us a 2-hour lecture on that.
Well, I think the other piece of this is relevant is before the current changes in carriers, so I don't know the numbers, but last year consumers had 100 different choices of plans. And I'm increasingly believing that they're actually not well served by that much range of choice, because you can't make these trade-off decisions easily that Cindy's talking about. If you could if you had a more narrow range. And so I think that is something that you can look
It's
at.
a big issue. And
Not for 17, but certainly for 18.
And just as we close this out, I want to note, again, I don't know if he's still on the line, but Jesse O'Brien has taken a real strong interest in transparency. And I think, in all seriousness, maybe we ought to ask Jesse to think about, for this summer or fall at one of our meetings, presentation, because you're right, the vision ultimately is that the marketplace merges with some transparency tools that allow the consumer to really make a fully informed and educated decision. And so you're absolutely right. And what's happened, of course, is we've sort of got a little bit off track on that ultimate vision. And I know, for example, that California is trying to do some things around bringing price transparency forward. And so that vision has not been lost. And I know Jesse and perhaps some others are still very passionate about it.
As you know, I'm involved in another insurance advisory group. And what I found is there's a lot of talk about transparency, but there's not transparency with the information we need. And I guess that's my summary.
Yeah.
Oh, I was going to go back to some of the carriers exiting the market and the state's plan for that, and just realize that the month of February is going to be a super important month. This people who lost their plan December 31st, open enrollment won't end January 31st. They'll have the whole month of February to potentially pick up a plan. Something outside of the state open enrollment targeted advertising for those individuals who lost coverage, who still have a 30-day window to pick up. That's an overwhelmingly large number of individuals in Central Oregon that are going to be shopping for plans.
It's interesting issue just to flag for the RFP and the technology discussion, because our ability to really hone in on those folks is different when we're working with healthcare.gov than a state has their own.
Yeah.
And I just have a quick question. What is I should know about the subsidy, but I don't. With the proposed increases in premiums, are subsidies a percentage? It's a percentage subsidy,
Percentage
right?
of your income you're supposed to pay towards your premium. So you would not be required to provide more of a percentage of your income just because of the price raises. So the federal government makes a difference for you, but that's only for those subsidy eligible folks. So anyone who's not, they're going to feel the full brunt of the price increase.
Which I think is huge.
Which is 32% of our customers.
And I've also seen that push more people into subsidy eligible. So this year I had quite a few folks that are like, no, I don't ever get. Oh, let's just check it out. You do, because the prices have gone up, and so I think that's also a really important messaging piece. Oh my gosh, yeah, for plan year 17.
Right, and that's part of what we get back to is that pool people changes. And what they're eligible for changes every year too. So that's again the importance of shopping, updating your information on healthcare.gov so that you get full benefit of whatever it is you're trying to get.
Has there been any analysis done of what the minimum wage increase does with income versus subsidy?
We did do an analysis. Dan did something. I don't remember what.
It would be too complicated for me to portray here, but I would be glad to circulate that folks are interested. Just a little snapshot.
I mean, the bottom line is it was a very modest effect.
Yes, surprisingly modest. Yeah.
Okay, we'll let you in 2017.
There was a bunch of tactics in 2016. We met our goals. So you guys have all this stuff in your packets. I'll just quickly, because we're on the messaging. Local Help was our top performer The normal click-through rate in our industry is like 0.8 or 0.08%. So you can see that
was awesome.
some of these messages did really, really well at getting people to click and then do something about it. All right. Do we have 2017, Victor?
Shannon, it's interesting that the top click-through is the one that you mentioned, which is local health. So,
Yeah.
The data and your personal experience with.
And all the research shows those people are happier with their plans and understand them better if they have local help too. So it's really like a
We're fortunate. Yeah.
Okay, so 2017 is going to look similar to 2016. It's trying to build upon the successes that we had. So basically, I went through the slides really quickly, but every single tactic that we tried did pretty well in comparison to benchmarks and in comparison to industry standards. So we're going to try to repeat what we did and add some extra stuff and refine our tactics so that we're doing an even better job. One of the first things that we're doing is we're actually starting everything sooner, including this discussion, so that we have some time. Like we did our agent storefront program last year, like what was it last minute? It was as soon as we could possibly do it, but it left our agents with very little time to figure out what we were doing, what was going on.
Yeah.
And we experimented with it as we went. And this year we'll now have more time to. We've already put out the requests for grant proposals. We'll be putting out the community partner one soon, so that we're ahead of the ball this time. We have time to make sure everybody knows what's going on, has whatever materials, information, contacts, whatever they need, that we have that all in place sooner. So open enrollment's going to be the same time frame, November 1 to January 31. These are, again, the larger campaign goals, right? We want to educate Oregonians and drive enrollment. The difference in overall campaign goals is we're pretty certain we can increase our market share, both in the percentage of QHP eligible and those who are specifically eligible for subsidies. I don't know what that increase will be, but I don't know that it would be as big as this year. We had the highest rate of increase of any healthcare.gov state, and that was amazing. I don't know if that's how much further we can go into the market before we hit that stop deadline, but we're going to try to increase our percentage again this year. Now that we know what's a reasonable number of actively re-enrolled people who actively shop, we're going to try to maintain that percentage. It was a high percentage compared to the national average, so we want to continue to be that leader in getting people to actively shop. And then the third is the same. We really want to continue to build trust and credibility. We made a lot of good contacts and started some good relationships with people, and so we want to continue to build that trust. How we developed the plan, took a look at what we did last year. We did some extra research. We did another customer survey like we did last year so that we could get people's direct feedback, because that's a little hard for us. We don't have access to our customers. It's all through the federal government. The federal government, in terms of outreach, does a national cable buy. They do the direct email outreach to our customers, and we don't really have a say in any of that. What they send, and sometimes it's really helpful, and other times it can be confusing because it doesn't match what people have heard or understand here locally. So we work with them as well as we can. We've even discussed trying if they'd be willing to send out some information on our behalf to our customers. We haven't heard back from them. But we're trying every way we can to try to make the messaging match. I know that whenever I see whatever they're doing, I try to make sure that our language looks and feels similar so that people don't feel like they're getting conflicting messaging or one, if there's something like, there's enough scams and things out there pretending to be state or pretending to be healthcare.gov. We want to make sure that everything we're putting out there feels credible. It's part of why the state logos in all of our messaging. And we really discussed a lot with we had surveys. We annoyed all our agents and community partners with surveys trying to get feedback from them about what worked, what didn't work. We wanted to be very honest about our outreach efforts and if we were giving them with the tools that they needed to do their jobs. You'll hear these names, Grady Britton and Metropolitan Group. Those are our, one is a traditional marketing company, so they handle our marketing. That's Grady Britton. The other Metropolitan Group is a social change organization. They really deal with grassroots outreach. They're the guys that are out there really helping us make partnerships on the local community level that provide materials and support to our agents and community partners. Really just they're facilitators for us for stuff that our small team just can't handle. So we need a brochure made. We need to make sure that the stakeholders that key audience, that they have input on how that's made. They'll help us round those folks up, make sure that they have a voice in it and that it matches the expectation in terms of messaging and look and feel. So I talked a little bit about this in the last one. Our campaign was a success, and our tactics did work. The surveys we did, once again, reinforced that local one-on-one help wasn't really important to people. Cost is still a primary driver. There continues to be a need for information. I talked a little bit about that. And then this big takeaway is that there were times during open enrollment where we would get information from the federal government. Granted, it was usually a month or two late in terms of being actionable, but we would get it, and I would have a couple of weeks left in open enrollment where I'd say, oh, we're not doing well in Spanish-speaking people in this area of the state. I really need to do some, I need to switch tactics and do something, but I didn't develop specific tactics for those situations because I didn't know I was going to run into them. So we're going to do a little bit, we're going to do some more targeted outreach ideas for specific key audiences that we think we're going to need to better reach this time and be prepared for those times when we get some data and it says that, hey, you need to have more young people in this area to be representative, that we have the messaging ready so that we can deploy it wherever we need it. So to give you a quick idea of the eligible in Oregon, this number you'll see, this is the number we use. There's different estimates of this number. It's really hard to get at how many people might actually be eligible, but we think it's about 360,000 people in Oregon. And if you know our enrollment numbers, we're at 147,000 on the marketplace. We still have a good portion that we could bring in. There's, again, we don't know what that penetration endpoint is going to be. It's not going to be 360,000. We're never going to get everybody, but we want to get as close to that end of the bell curve as we can, right?
So what was the off-exchange enrollment number?
102, I think. So we've seen that switch, right? So last year, off-marketplace had slightly more than on-market, on-exchange, and we've seen that switch. So that's really the increase in our enrollment this year is primarily people moving off-exchange to on-exchange, with a slight decrease in uninsured and eligible population. So we're doing a good job at getting people to see the value of the marketplace who are already buying insurance. The really hard thing for us, and I've been asking this question at all the national forums, is like, does anybody have any idea how to really make headway with the remaining uninsured? Because that's, I think that one is much harder to make significant inroads going forward without changes in health law or something else that makes it more affordable and better plans.
So I'm really intrigued by that. I wonder if we could just do a quick pause, and I see people sort of nodding. What's your personal experience tell you about the messaging for the remaining uninsured versus the off-exchange? I don't know, as we refine our messages each year, refine our marketing tactics, and I know that's kind of path that you're on. What does your experience tell you would be a way to reach those folks? Is it a different method? Is it heavier talk about the penalty?
I would say just go to them. I mean, I think that's the biggest. I think the people who haven't purchased and who are uninsured aren't going to actively call one of us or go online or do something. But if we are where they are and like, hey, we have this thing that's really easy, come, oh yeah, sure, I'll do it because I'm already here, So I think that would be my 2 cents is, and I would say the remaining people that I've picked up during open enrollment were people that I was at a place that was convenient for them to get the information, and they got it while they were there, but I don't think they would have necessarily sought me out for that information,
Yeah, I think definitely. I agree with that. Every touch is another, you're losing 30% of your people that will actually show up if you're trying to get the company the second time. Mm-hmm. So getting them to these events with the information they need to sign up that first time
Yeah.
is really important, because that second time is just not going to happen for a good chunk of people. So I guess a lot of the health literacy and preparedness of what you're going to expect for the sign-up process, and I guess really the health literacy education is
And we're-
to
sign up events like advertising in the rural areas. Like we've tried grassroots to do some, but they aren't well attended. And I think I don't know, it's advertising of what the issue is, but more.
There was an interesting LA Times article about what's the town? One of the mill towns here, and health insurance was part of it. It talked about a town where economic opportunity was decreasing, right? And you had a lot of people that had needs for all kinds of financial services, but health insurance was mentioned. And it was interesting because we were mentioned in there in a roundabout way. There was one of our insurance agents that we work with closely who was who was at the local community college providing a talk about health insurance. A third of the group got up and for ideological reasons didn't want to stay and listen to the lecture, but there were people who stayed and there were people who signed up at that event. And those were some of the people we're talking about. They weren't easy sells at all, right? It wasn't even about telling them that this is important. They understood how important it was to have health insurance. It was just hard for them to see the value of it and to, I don't know, it required those multiple touch points. It wasn't this single time where they knew, right? It was just getting them where they were.
Right.
The folks were already going to community college for other reasons.
Mm-hmm.
And that was one of our big pushes at the end of open enrollment was community colleges. We're having to think more creatively about how we do outreach, and that's part of why we have a team that now goes out into each of the regions, is trying to figure out where those places are that people go so that we can have a presence there, whatever that presence is, whether it's through a local organization or a local insurance agent, or even just at the pharmacies, having a little sticky note that has our number on it or something. We're looking at all those different ways, and I don't know exactly what is going to turn out to be effective, and that's why we meet kind of weekly about it, because it's a little harder to quantify than these higher level, like, we enroll X number of people.
Well, it's so different depending on where you are in Oregon.
Yeah.
We really focus our rural efforts in a completely different way. Right. We do a Portland audience, but trying to be where folks are at the point of the decision, or at the point of the impact. So whatever, when they're experiencing unemployment, when they're buying, for, about to pay for a prescription that they can't afford, those at those points where it's going to be meaningful versus just being available,
Right.
I would have to agree with what you touched upon, Joel, and that is ideology of individuals, because I do run across it a fair amount. And a lot of...
you do?
Pardon?
Darn!
I can't believe it.
There's cut it.
Yes. So the other thing that has come up with me, or a fair amount with me, is the ministry share. They individuals who purchase. It's like a group plan. It's like the Oregon Medical Insurance Pool in a way, except you're purchasing very low cost and qualified insurance.
No, it's not qualified.
Well, yeah.
You can
It
file
is
for extension, but it doesn't have the minimum
qualified.
essential coverages because they don't cover preventative or birth control or all sorts
Right,
of
they
things.
don't, but they've got the exemption. There's a federal exemption.
Right. Yes, correct.
Phase-based, ministry share,
Yeah.
medical share.
They're becoming-
There are different names, but it's a pool of people that pay just a nominal premium, and then if something does happen, there's no preventive or anything like that. It doesn't have to follow the 10 essential health benefits, but it does provide for those who ideologically don't agree with the federal government telling us to have qualified plans. So I'm just curious if we have any information on the numbers.
That's not 100,000 people. It's not very many people.
Yeah. Okay.
There was I think it was Oregonian. I don't remember. There was an article about it recently that was pretty good. That just kind of set the stage. When it comes down to it, if you're not going to convince anybody, that's why our goal at the highest level is to make sure people are going to have some sort of coverage. It's not coverage that might be the best or might be most cost effective. And and we see that in all of our outreach efforts, because you're talking about 360,000 out of 4 million. We're not a large portion of the total market. So a lot of the help that we provide isn't necessarily for the marketplace. Rob can tell you that having the community partner programs, it's going to see primarily people who are eligible for Medicaid. We're system integrated Medicare. Our audience is growing a little bit, right, so that we can provide messaging to a larger group, but still, like, this is a niche group, and so we've had to really change how we do outreach so that it's inclusive of all types of coverage, so that we're making sure people have the opportunity to understand for the whole family, right, because kids might be on OHP, grandparents on Medicare, and parents might have a chance to have marketplace coverage.
So Joel, in light of what we heard earlier, I'm really eager to hear the strategy around both multicultural audiences and the young adults.
Okay, so just a quick note, we think there's about 216,000 who are subsidy eligible of the 360,000 who are QHP eligible. So the other, these are not mutually exclusive, right? So we have traditionally uninsured and uninsured, multicultural audiences, and young adults are specific subsets of the 360,000 that we really want to reach better. Young adults and specifically Latino Hispanic populations, that's what I was talking about earlier. We're going to do about 2.5 months of research where we're doing focus groups, and then after that, focus groups throughout the state to try to get a better understanding of the audience and what might be the best way to reach them. And then we're going to do some, I don't even know what to call it because I made it up on the spot, but it's like focus groups over time. So we're going to take some key individuals and follow them throughout the year, because it's not, you do one touch point when people may or may not be thinking about insurance. You're not going to get the same information as understanding where they are in different parts of the year, if they're hearing our messaging, if they're hearing things in the local community that change their mind about what we're doing. So we're going to be doing that research over the next year, and again, I'll share the results with you, and we'll have, I can come back and provide you with our specifics about what our findings are. In fact, Barry, we could share the 2-pager that shows our plan for the research, so you understand what we're trying to do and what we're trying to get. I don't know what the end result's going to be. We think we have some ideas about how to reach young people. We think we know where they are, but honestly, I don't want to say without having done actual research into the topic, because we've tapped all the resources we can in terms of looking at other people's studies. I've seen so many studies about the remaining uninsured, but none of it tells me exactly how to reach those folks in Oregon effectively. For multicultural audiences, we are planning to do some more. Actually, I should just move on to the slides, because this is just talking about audience. If I get to some tactics.
Can I?
Yeah. Go ahead, Joe.
Yeah. If we go back to the multicultural audiences. Now, I'm going to push a little bit on this point.
Okay.
I mean, I think looking at overall what the goal is, right, is really to give people access to health insurance coverage. But I think that all of us in this room, would think that it is because we want to make people healthier, not just give them access. And I think in the literature out there, we know that there are pockets of people who are disproportionately affected and have health disparities that are just off the charts. And so I would like to see that our strategies are also reflective of a consciousness of that reality, because we are trying to address the health of our communities, not just give them access. So a blanket like saying multicultural audiences doesn't really show intentionality there. So I think we need to also raise, in terms of we're raising the young adult population, but also really focusing our strategies on that reality that there are people who are marginalized, people of color a lot, cultural groups that really feel the brunt of health disparities in general. And so, you know, one of the recurring strategies that we're seeing that is really effective is that person-to-person local health. Well, how many of our local certified agents are people who come from those communities, or people of color who reflect that community? Because I think even that, having that really brings it to a different level of impact as well within our communities. People have said this, you know, throughout our community, saying if there's a person on the other side of the table who looks like me, who comes from my community, there is that credibility, trust factor that enables community members to, you know, come in role and take charge of their health. So I mean, so if we are being intentional, and this is one strategy, then we say, well, then how do we recruit, certify people from the communities that have an overrepresentation in health issues, health disparities, so that we are really targeting our strategies in the most effective and, you know, culturally community-informed way.
Joe, I really appreciate that comment. And actually, if you would continue to kind of push us on that, because I think it's really easy for us to forget or just not even understand. So a couple of things that we're doing this year, which are new and exciting, but we're still kind of like, you know, we're in a gray area, so your guidance will be really helpful, is for the Agent Storefront program. People apply to these grants to be storefront agents, and they have to go through kind of a rigorous application process. And we have weighted more heavily those folks who are bilingual, who can explain their presence in different communities within, how can they make an impact in their community, and if they can reach underserved populations, they score more highly. So we think that might help. But the language issue, especially having access to more than just, you know, Spanish and Russian and Vietnamese, and some of the ones we primarily think of, has been a big hurdle for us. So that's been a big key, is to try to find out where the local help is, actually in that person's language that's helpful. The other thing we're doing, I'd love for Rob to touch on it, is we're doing a faith-based outreach program and partnering with Dolly England, who some of you may know, which is a name that I just hear all the time in the Vermont community. I don't know, Rob, you want to just touch on the faith-based outreach?
And actually, if I could go back to and talk about kind of, that's one of the benefits of the community partner program, is that we do intentionally seek out community-based agencies that serve traditionally underserved communities. You know, the focus of that program is to do outreach to those communities and make sure that those individuals are receiving the type of care that works best for them in the communities that they live in. So, and we're continuing that this year. Last year, we really sought out specifically organizations that serve those groups that are underserved by health insurance and by healthcare. And so, by partnering with them, we're able to provide assisters that come from their community, and they see the faces of people that they recognize and they go to every day. So I really feel like that's the benefit of the community partner program and what we have to offer through the marketplace.
Yeah.
In terms of the faith-based outreach, that's another group that we really feel there's opportunity. And so by working with the faith communities, we're also touching on communities that are tightly knit, and they're it's a way that we have these sort of informal leaders, that formal and informal leaders within the community, that can spread the information about what's available through the marketplace. So we work with a lady named Dolly England, who is very tied into the faith community. I think her family, her father's a pastor, and she's very familiar with that. And we didn't want to step in and say, we know how best to work with this community, so we really wanted to get someone from the community to work with us and help develop the outreach plans. We're in the opening stages of that. And then throughout the year, we'll be putting on events with churches and working with the church to try and develop the message to go out to the people that are in attendance. So we really are trying to be as intentional as possible of taking them. When we say multicultural audiences, we're looking at each culture as an individual culture, because one message is not going to work for all of them. And we're really trying to get people from that culture and from those groups, like Joel was saying, with these cohorts that are being developed. One of the strong efforts that we're making is with Latino cultures and Latino groups, and trying to make sure that we have people from those groups speaking, not necessarily on behalf of everyone that belongs to that culture, because that's impossible, but at least those voices are part of the conversation as we're developing the plan. So, because we don't, those of us who don't belong to that culture, we don't know best what's best for them.
Yeah, I'm going to jump on in here, Rob. So I've been on the board of Central Latino Americano for many, many years, and I'm pretty deeply involved with the Latino community in Ling County. And in 2015, they received a grant to help as a community assister because, for the obvious reasons that you've articulated and that Joe has articulated. And so they had 5 assisters working on helping people enroll. So it was very serious, taken seriously, I guess you would say. Then in 2016, they did not receive the grant. So while they continue to enroll, they now have like one part-time person who, doesn't take it very seriously because it's taken away from other social services that we do at Central Latino. And it's not, when you're a nonprofit, every dollar counts and you have to make those dollars spread. So I was very disappointed. I felt like the Latino community in my area, because Central Latino is the social service agency in my area, and it felt disrespectful when they did not receive the grant.
Yeah, I think as we're looking at the applications that come in when the RFGP actually releases, which should be sometime this week, we need to take into account the perspectives that you're talking about and make sure that we're looking from a statewide perspective. I think last year we really focused heavily on the Portland metro area because we had a lot of community-based organizations and there was a large population that was available to enroll, so we wanted to make sure to hit that population really widely. One of the partners that we worked with was Oregon Latino Health Coalition, and so are you familiar with them? So they work specifically with rural federally qualified health centers, and we felt like they were a really good partner for us because they could get out to those communities and make sure that smaller organizations that focus on Latino healthcare could receive this funding so they could sign people up. Obviously with the RFGP not released yet, I don't know whether or not they'll apply again this year, but our hope is to take a really statewide perspective and look at organizations like you're talking about. Hopefully, limited funding is a reality that we have to deal with, but we're really going to try and spread the wealth as much as we can so that we are available throughout the state.
Rob, I would encourage you to tap in. You have some expertise. As I'm looking around the table here, I'm looking at Sean, Claire, and others who are working with a lot of these organizations, maybe in a slightly different way, but through their work. Tap into us, and obviously Joe, who's raised this for us. And I would, this is something I think this group is not going to let go of, and we're going to be pretty tenacious about, because as I was watching Joe raise the topic, I saw nodding heads, and people are passionate about this. And even the word multicultural, and I know it's put up there with the best intentions, and I want to acknowledge that as no way of criticism, but to me it does feel like you're lumping a lot under one big word. And I know there's a lot behind that, and so what I would encourage us to do, both as staff and as a committee, is try and sort of peel away that word a little bit and bring forward those strategies. We have people working extensively in the Latino community, Native American community, and we want to support you and the entire team in doing this outreach in a meaningful way. It's really helpful.
I think the other thing that at a macro level we can be looking at is talking about sharing the quote-unquote wealth, focusing on the quote-unquote wealth itself, and figure out if in fact we can better resource these kinds of grant programs and efforts and partnerships and those kinds of things. Understanding that, sort of the conversion costs is completely different because it's a completely different job that we're trying to do, and recognize that and up our financially.
So just a few minutes left. Great presentation. We've covered a lot of ground. You can see people are passionate, so we're not going to let you far from our site.
Welcome to the webinar.
I never actually got to
Organizers or panelists on the line. When you are ready to begin the presentation, press the Start Broadcast button on the GoToWebinar control panel to allow all attendees to hear you. This system will notify you once you begin your broadcast. The broadcast is now starting. All attendees are in listen-only mode.
Providing access, again, like it's about providing that overall coverage for the state in terms of organizations we partner with. And And we were actually last year trying so desperately to give away our money to any organization. It was really hard actually to sell people on being our partner last year. But hopefully with the trust and credibility that we've built up, Rob will have a much easier time giving away money this year. And we can get some more organizations in the mix to do the work. Do I have any more time? Or
you do have a few more minutes.
Okay.
Leave us with some parting thoughts.
All right. So I'm just going to quickly then over your tactics. This is what we're again doing at the state level. There's stuff that the federal government is doing, but we're going to do a digital paid media advertising. And what that is that's anything related to the internet. It's your digital radio. It's your search engines. It's catch people when they're thinking about health insurance. Let's try to capture them when they're doing that search or when they're listening to the radio during open enrollment and see if we can't get them to click. Earned media, we did a really good job last year getting a ton of stories out there when a lot of other states had trouble. And they were positive stories for once instead of really negative ones. So we're going to try to do that again and try to get into some publications that we did get into last year. We ended up being mostly the same ones over and over again. We want to really hit some of the smaller markets. We'll be doing specific ads in Russian and in Spanish. Last year we did print and radio. This year we want to add some Spanish TV. We're talking with Univision about that because we think that might help our outreach. We produced so many materials. I'm constantly cleaning them up to figure out what actually worked, what didn't, but we're going to continue to produce as many individualized materials as we can for specific audiences. This process takes a while because we usually have somebody help us translate or make it culturally appropriate, and then we have somebody else check to make sure that that's actually what we're saying. I can't read Russian, so it helps to have someone who does. So we're trying to create more and more ways that people can have something in their hand or have something online that is helpful for them in their specific circumstance. We're redoing our social media a bit. Last year it was just about we had a presence to make sure we were part of the conversation and so that we could do advertising on these mediums because that's very, those ad tools are really effective. This year we want to actually increase our social media profiles and make it more about connecting with our partner organizations, create another touch point for us to provide messaging or to get the word out through them. So that's going to be all Barry. She's going to be out there shaking hands saying, "Are you my friend on Facebook?"
That'd be great.
So Rob talked a little bit about this, but this is a huge component, right? So providing support for community partners, insurance agents. So we have specific grants available to X number of agents and community partners, but even the ones that aren't our actual grantees, we want to make sure that we're providing training, providing materials, doing outreach, making sure they're on our newsletter so that they have information, because the more we can have all be saying similar things and having accurate information out there, the better. And Rob quickly touched on, like, we'll do some specific training about like HIV/AIDS issues or tribal issues. We'll try to make sure that we're providing constantly good information so that they want to engage with us and that they're getting something out of it each time. That they're rewarding essentially for every time that they interact with us. What we call the agent storefront program, we also call them enrollment centers. So this is an idea that we took from other states where they just, instead of creating an enrollment center themselves where you have to pay the overhead, you don't know if people are actually going to walk in the door. We took an idea that some other states were using where it's basically you partner with agents who are already out in the community, who already have storefronts, and you use their store as your enrollment center during open enrollment. And we had 24 of them last year. It was very interesting to see. Some were amazing at getting the word out there, doing that outreach and promotion. Others were like these just driving enrollment like crazy, even if they didn't do that much outreach. So what we learned from that last year is that it's not a one-size-fits-all kind of grant situation. We want to have different grants for different things. So we have a promotion. It's not really even a grant because I'm not even giving you money, but it's really like a partnership saying, hey, this is a trusted resource for health insurance information, and we'll provide them with materials and other things so that they can really get the word out to these agents who have ties in the community. We're going to do an outreach set of grantees where we're going to give you some money, we're going to give you the expertise of our marketing firm to try to you're already in the community, help us raise the profile in your community. And then the third one is going to be for an actual, enrollment grant where, hey, we expect you to enroll scores of people, and we're going to give you some money to have an extra person, longer hours, whatever it is that you need so that you can help us drive those numbers and get that one-on-one help. And then for all of these, we will refer people to our website, other ways, so that there's a real benefit for the agents. And the promotional partnerships is kind of similar. It's going to be with any sort of organization that we think has an influence in the community. And I count Dolly's contract as one of these. It's an example. Like, she had specific insight about a community, and rather than us pretending we know how to reach folks, we're going to learn from her, use her as a resource, make her essentially part of the team. And that could be as much as involved as that, or it could be just helping pay for like a relay race or something that's about health, or just providing a little bit of funding here and there. And we have ways of trying to figure out, are we reaching people through these promotional partnerships? Is it worth our paying for our buck? We had about 12 of these partnerships last year. I hope to have a lot more this year.
Well, let me ask you, in the interest of time, I want to ask you just to jump ahead. People have the budget in here. That's great. You've gone through the tactics. Now, as I'm yakking, I'll let people see if they have questions. But go to the measurements. One more. Or either the key performance indicators. Don't read through them all, but maybe pick a couple and then talk about the measurements. And then what I'd like you to do is just quickly close with the timeline so that we all understand what the timeline is, and we can sort of be looking ahead because we're going to ask you to be reporting back to the advisory committee on a regular basis throughout the remainder of the year, consistent with this timeline. So,
okay,
go ahead, please.
So these are very similar. So I gave you guys a 56-page report about last year that went through each one of these measures and said, or are we actually doing this? And then provided some numbers to back it up. And most of these questions are the same as they were last year. I might have dropped one or two because, like, I wanted to ask, are we really driving traffic to healthcare.gov on the website? But I don't get those numbers back from healthcare.gov about how many Oregonians go to their website. So that's not something that I can really measure or ask. So they're slightly different, but overall they're about the same as last year. And we plan to do the same thing, is where we ask ourselves at the end of the year each of these individual questions about, are we really reaching people? Are we giving them information that's actually helpful? And you measure it. On the next slide, you'll see how we're measuring these things. This is the data that I have access to. I wish I had access to more data so that I could refine our tactics even more. But this is the stuff we're looking at. We're looking at enrollment numbers. We're looking at information from our community partners. That's why we're sending out surveys to them and saying, hey, did we do this effectively? Did we do that effectively? We budget each year. Consumer surveys are not cheap, but we do them every year because we're trying to figure out, are people seeing our advertising? Do they feel that healthcare.gov is helpful? Are we seeing an improvement in terms of how many people feel satisfied either with the product they're getting, the service that they had, the website, all of this stuff, so that we have this constant feedback loop so that we can refine all of our measures. And we actually went pretty overboard in terms of collecting data and only using tactics that we could measure because of what I talked about at the very beginning. There was a lot of skepticism about, you're just going to be throwing this money away and you're putting out commercials with guitars, and there's no way of measuring if that's translating into actual enrollments. And so it's been a learning process about what data we can collect, what's meaningful to us. This is what we have right now. I would love to be able to have access to more information, and this is something we're in constant communication with healthcare.gov about, is we would really love to be able to have number-level data so that we can start to see in individual audience segments, are we making a difference? Because it's really hard for us to tell race and ethnicity data. For example, self-reported data, I only get the macro-level data for statewide. I have no idea how well we're doing in individual communities. It's really hard for us to figure out, how much more effort do I need, what type of effort. I can't even do the basic thing of knowing how many people there are that we're enrolling. So this is a constant challenge for us, and we're working to try to improve it. And I imagine that all of this will change as more data and information becomes available as we go. In terms of timelines, right there in the second bullet point, right? So we created this really high-level plan based on last year. We'll take your guys' feedback that we heard here, and as Creative Britain and Metropolitan Group help us develop the actual detailed plans. We're going to use that feedback to try to create something. You know, all I've given you here is basically the highest level. This is what we have money for. This is what we're trying to do. In terms of individual plans, like Rob's working on an individual faith-based outreach plan. We created a year-round calendar now for outreach topics and stuff. That if you guys want to see any of this stuff, please let us know, because we're constantly refining it. Nothing is set in stone yet. We're just trying to amass our plans so that we're doing this in a purposeful way.
So we're not going to micromanage the marketing and outreach, but I do think based on what I've heard today, people want a chance to look at the materials and make sure it reflects the emphasis that we've talked about, some culturally specific outreach, making sure in communities that we're working close with the group that we know in Lane County is the main group that's going to be able to reach out to Latino residents of Lane County. So we'll count on you to find that balance of keeping us informed and taking our input without, like rubber stamping specific materials.
So I can see some key points on here where I think I'll want to come back to you guys and Robin and Michael. So we're going to have creative in July and October. So that's what our ads will look like, stuff like that. I want to make sure you guys see that. I think it'll be really good for you guys to hear about our agent storefronts and community partner grants, saying, okay, this is who we're planning to grant to, this is what we're planning to, so you can get your feedback on are we missing anything? Is there ideas that you have with the specific knowledge you have in your areas about things we want to try for those. We're going to start our trainings in September. Those topics, we have some ideas about initial topics, but if there are other topics you think are really important for us to make sure that we're providing for our partners, please let us know, because we'll want that and queue it up, and make sure that we have we're representing it as much as possible. Any ideas that you have about how to better reach people. And in terms of other checkpoints, obviously during open enrollment, we'll try to share information about how we're doing. We get those enrollment numbers weekly, but we can roll them up into any way of reporting that you guys want. And in terms of looking at success of how well we did, we should have something for you in probably March or April of next year to be able to look back at all the work we did, and then again come back to you and ask for feedback about that.
Yeah, and what's interesting, a number of us will be on the advisory group for a while, so the year-over-year comparison, hopefully we're all on a learning curve. I know I am, and we'll be able to add even more value. So with that, we're going to take a break.
Yeah,
let me
one quick question.
just ask for questions. Yeah.
Within the enrollment data, can you see retention?
I can see percentage of customers who are returning, whether they're actively shopping or not, but I can't see below that, really. Like, they only give us a summary level data.
Again, given the disruption in the market this year, it seems to me that should be specifically flagged within enrollment. We should really have a great idea how many people we fall in some form.
Yeah, it'd be interesting if we could get it per area so that we have a better understanding. Yeah.
Pat?
And then I'm going to move on, but quickly, and this may be as much for you, Dan, and Ken, as it is for Joel. In the area of marketing and outreach, do we have an opportunity to work more consciously with carriers around targeting and messaging? I mean, it seems we've sort of got a moral imperative to get people who need access to healthcare covered, but there's also a business imperative to broaden the pool and make sure we're not just covering people who need lots of healthcare, and we're covering people who don't. And I wonder if that's a place where there's enough of an intersection that we can work better together with carriers to focus on that.
Definitely in the younger populations, right? It's in your best interest to have that better balance.
Well, and sort of to combine the 2 points you guys just made, I'm concerned particularly where there's market withdrawals or where there's pricing that feels like a market withdrawal in some cases. I mean, let's be realistic. So what are the communications to those people who are either looking, like Maria, or looking at carriers just leaving her community, or where the pricing is such that people are forced to shop? So I don't know what that kind of communication looked like.
It does feel to me that maybe there's some opportunity to, some safe havens of doing some collaborative outreach across carriers that are in the market. I mean, many of our markets will have dramatically fewer carriers, so there are 3 or 4 in a market. Could we work together to do outreach and something?
Yeah, I think it's something we need to look at.
Cindy, and then we'll go to a break unless I don't want to cut you off if there are other comments.
So, just as a subscriber, I have some questions about, are we driving people to healthcare.gov and do they use healthcare.gov? So, I was definitely driven to healthcare.gov, but I don't know what benefit it gives me. In fact, it thinks I'm not covered. So there's a disconnect between Oregon healthcare.gov that drives me to healthcare.gov. It apparently has no information pertinent to me. I get notices.
Healthcare.gov.
Yeah, I mean, I get messages. I don't get anything from Oregon healthcare.gov.
We don't have access to our direct customers, right?
So what I just want to suggest is that I'm not sure what the benefit of driving people to healthcare.gov is. Is it just subscription?
That's how they would enroll through the marketplace. There's no other. We don't have, again, right, our own technology, so we have to drive them there if we want them to get access to subsidies or just the slightly increasing benefits of going there in the first place, which is that they do have consumer tools now that are getting better. So even if they didn't buy on the marketplace, it is a place to A, check if you're eligible for financial help, and then B, to be able to at least do some quick comparison of plans. They didn't really tout or promote their plan choice, their consumer tools last year, but it's something that now you should be able to go in and anonymously, so you don't have to sign in or sign out. Go in, put in your information. You know, I use this much healthcare. This is my family size. Be able to look at your choices of plans, and included that now this year they'll be checked to see if your doctor is covered. They're adding more features as they go. It's not as fast as we hope, right? But they're adding more tools there to make it a useful tool, even if it's not how you end up actually enrolling in the end. If you want to decide, oh, I saw a plan on there from Kaiser, but I don't want to deal with healthcare.gov, you could go and enroll directly through Kaiser. But
No, I'm forced to. So, I mean, like I said, no, we can't enroll you. And I was a renewing person. You have to, no subsidy. You have to go to healthcare.gov. And so, just a point, there's a disconnect for me in the market, of my health insurer, the marketplace.
Yeah.
You know, I was driven there by my health insurance provider, not advertising and outreach.
So you didn't work with an agent, Cynthia?
No, I was just renewing. I renewed, or was going to renew, was on the phone with Likewise, and they said, no, we can't do it here, you have to go to the marketplace.
Other closing thoughts? That's helpful, especially from our consumer member.
This is Jesse. Could I jump in for just a second here?
Yeah, Jesse, go ahead.
So what Cindy is talking about is actually something I've heard from a few consumers, that they, even though they think that they are not qualified for subsidies, or they definitely aren't qualified for subsidies, that carriers have been directing them to the marketplace and saying that that's the only place they can enroll. And I find this a little bit confusing. I did notify the market regulation section of the Division of Financial Regulation about this, because there might be a market conduct issue there, and I think they're looking into it. But that's not what insurance companies should be doing. They should be, if people are trying to enroll with them directly, they should be allowing that to happen and not turning people to the marketplace. So I think there's a concern there that hopefully the regulators will look into in more detail. I don't know whether this is just a handful of incidents or a broader pattern, but it is something I'm a little bit concerned about.
I wonder if it's a misunderstanding on the carrier side, potentially, or
no,
something.
I think over the last couple of rounds, we have seen carriers that are interested in reducing their exposure, and they've been kind of casting around with tools available to them to effectively do that. We talked a little bit ago, a while ago, about the fact that because of changes in subsidy levels, a price increase by a carrier that in a normal market would cause people to pick a different carrier, the customer doesn't see all of that price increase. And so it's stickier market than maybe we thought of originally. And so we've seen different carriers play with different things like making direct enrollment more difficult on their website. I don't know that I've consciously seen anybody completely abandon it, but I've seen one carrier go to paper application only, for instance, for direct enrollment. And so there's sort of an interesting question about what should be okay and what shouldn't be okay. Now, the one that I'm pretty sure shouldn't be okay is changing agent commission levels. That's pretty much telegraphing that agents steer people based on the commissions that go to them rather than what their best choice is, and that's problematic in the extreme. So it wouldn't. I'm not familiar exactly with a complete shutdown, but this sounds like part of a suite of things that are going on that we're trying to get a good regulatory handle on.
So with that, if I can, yes, please, Sean.
Last point, not to belabor it, just please target people who are also eligible for Talon and on both programs, and once they don't know that they're qualified for health as well.
No, good. Those are good points. I never want to lose those. So terrific timeline, and then what we'll do is Barry, we'll count on you and the team to bring back just to find that right timing in terms of looking at the materials, making sure it reflects the discussion we've had this morning. That can be you guys, it can be great written, and that's all the group together, however you want to shape that. And I do think it seems to me like people are looking at the written materials in addition to the discussion, so it's helpful. I know you gave us a lot of stuff, but it was helpful. So let's take a 10-minute stretch break, bathroom break, and then we'll come back right at about 5:02. let's come back together if we can. The moment we've all been waiting
Oh,
for.
da-da-da.
Barry, Leslie.
So we saved a bunch of time here at the end, and we do have, Pat, I think I will at the public comment if we have time, if this doesn't just go crazy and take us till 3. I know people have seen in the news about the initial rate filings, and I think we're not going to dive into those, but what I'm going to ask you to do is just remind people the general process for reviewing those rate filings, and that's a different part of your team, Laura Callie. But you can talk just about that process, because even though we're not here to do that today, it affects our work, and we just want to, I think, probably a lot of questions about what we're seeing in the marketplace. I know Ken in particular has talked about the volatility in different parts of the state, and so we'll do that, but we'll do that towards the close. So right now what we have is we know that one of our big assignments as an advisory committee is to think about the future of the exchange technology platform. We all are well aware of the history here, so we take this very seriously, and I think the team at DCBS and the marketplace has done a great job, even as the advisory committee was being formed, of putting us on a successful path to understand what our options are, what the trade-offs are, what the cost implications are. We're well aware that this is the legislature's decision, not ours. But frankly, on behalf of Jesse and me, Pat and Barry, we've been on some calls with legislators, and they are looking for our input and our advice from the advisory committee. So I want us all to be very cognizant of the fact that even though we don't get the final say on this, our input is critical. And what we're going to do today is review the document that the team has put in place. We'll let Barry go through that in some detail. We'll ask a lot of questions, and then we'll provide some advice. And what we'd like to aim for, if we get there and people feel comfortable, is to actually take a sort of a semi-formal vote and indicate what we believe the right path is to recommend that Pat and Barry take back to legislative leaders in May. And that'll happen later in the month, I believe, so coming right up. So if that makes sense to people, we'll go ahead and turn it over to Barry and ask you to walk us through the analysis. You've brought some legal support here.
Just kidding, I need it. Yeah, I love lots of support. Well, and I was telling Dan, I'm really just going to be a discussion facilitator here, because it's really important that we gave you this big analysis, that I think we break it into chunks and really kind of talk about it in chunks, because each chunk is really, if I were trying to figure out, gosh, what would I want to recommend about this, I'd want to understand each chunk before moving on to the next. So I'm just going to really guide us through a discussion more than really do a lot of talking at you, repeating what you read in the analysis. I do want to just lay a little bit of groundwork in terms of people who are going to be helping me. John McCormick is here from the Department of Justice, and because we used a RFP, request for proposal process, there's a lot of legal nuance here, so it's really important that I don't overshare, and he'll stop me from doing that. You will certainly have questions that I cannot answer or shouldn't answer related to the RFP, and so John's going to take any and all of those.
So should we be sitting closer to you?
You know, I know you can't hit me from there, can you? Like, he can glare at me.
You have a nice triangle.
What are you going to throw at her?
He can glare at me.
He's got a stack of empty supplies.
It'll be the panic look on my face that will tell John, step in. Also on the phone, we have Gary Helmer, and he is really the person who crafted the numbers and the analysis that you read. And so there, I'm sure, undoubtedly questions that we just didn't think. You guys are a really smart group that you would thought to have asked that I can't answer, that Gary's going to try to attempt to answer, or will be able to answer. So we'll let him chime in as needed. So just a couple of high-level, to make sure we're all starting in the same place, and that is that I think everybody here read that the reason that now is a good time for Oregon to determine whether or not we want to stay the course and continue using healthcare.gov or switch to our own platform is because beginning in 2017, we're going to be paying 1.5% of premium. And just to give you an idea of kind of the rough number of dollars, that is something like $6 or $7 million. And then in 2018, we're going to be paying 3% of premium. I think Gary has the exact numbers in here, but it's something like $13 million. So it's a lot of money.
And when you say we, that's in the global context, not we, the marketplace, directly.
Exactly.
Barry, can you translate that very briefly into sort of an average PMPM? Because that's a big one.
So right now, we've been, I think if you include, oh gosh, I don't think I can.
It's about 1.5 would be about 450 PMPM, and 3 would be about 9 PMPM, because our, or maybe a little bit more than that, because our previous 966 PMPM was 2.9.
We have 2.9% now is what we spend on the program.
Yeah, so actually probably a little bit, somewhere between 9 and 10 at $3, and about half that at $1.50.
I don't know, Gary, do you have exact numbers on that?
Hi, this is Gary Hilmer. I did not hear the question. You were looking for a PMPM of our current program. Is that what you're looking at?
Can you tell us what 3% of premium translates into in terms of a per member per month cost? You know, we can do, Gary. We can just move on.
And part of what Gary should be struggling with is those are both targets.
I'm sorry. I'm just not getting the question clearly.
You feel like you can't hear it, or you don't understand it?
It is not clear. No, I cannot hear it.
Can you convert the federal 3% of premium charge into a per member per month easily on the fly with what you have at your disposal?
Okay, so that was $14 or $15 when we were doing the analysis. For the rate setting, it was $14 or $15 per member per month.
Okay. Thank you, Gary. So that is, the cost of healthcare.gov is one of the primary reasons that we thought this is a good time to look at it. The other reason that we had on the table that made this really an important conversation is that the federal government was requiring us to have a SHOP, or a small business health options program, up by 2017. We recently, you all saw the announcement from CMS indicating that states had actually 2 more years to complete that responsibility. And so, and I think this group already knows that one of the reasons we think that they delayed that implementation timeline is that SHOP just hasn't been as successful nationally as they hoped. In fact, one state has better annual enrollment numbers than other states do in terms of ongoing enrollment. And so I think they were not looking forward to a conversation that would include a lot of other states asking for that requirement to be waived, which would really heighten the conversation about the fact that SHOP's been a struggle. So what I think that was the second reason that we were really interested in having this conversation and really figuring out what's best for Oregon. But I do think for the sake of this conversation, what folks need to know is that SHOP is really not on the table right now. Because we've been given that 2-year extension, and because there's obviously a lot more we need to learn from small businesses and a lot more conversations we need to have with small businesses, we think that that's a real gift from the federal government to give us more time to really get it right, versus just throw something out there that hasn't been successful and small businesses often told us isn't helpful. So this is really just going to be about the individual technology this morning.
I'm going to just pause you there, Barry, just to make sure everybody got that point about the SHOP, and that will be a focused agenda item in coming months, and we're not going to lose sight of that because that's a big piece, but it's a tough one, and I know we'll have a focused discussion, but I think it's important to know that it's sort of been carved out from this discussion. But I know we have a lot of people around the table who are thinking about impact on small business and SHOP or not SHOP.
Yeah.
So go ahead.
So you have 2 options in front of you, and obviously they are to continue using healthcare.gov, which this group also knows we've been using for the last couple of years, or to switch to a private vendor technology platform that has been successfully deployed in another state. And that's the RFP that we've been talking about that we released a few months ago. And that was really a solution that has to be ACA compliant, has to be working in another state, and essentially we could be not completely dragging and dropping to Oregon, but it was kind of that simplicity in mind in terms of how it would work in Oregon. We had 4 proposals that we received by the RFP deadline, and one of those did not meet the minimum requirements, and so was eliminated from consideration. So the analysis that you saw is actually just based on the following 3 proposals that we had data for. So the way we're going to break this out in terms of discussion is functionality, cost, program impacts, and consumer impacts. And although you don't really have scoring sheets, obviously, I think just talking about it in those kind of 4 buckets is a good way of going through and figuring out what the concerns are, what we're not thinking about, what's most important for Oregon, and obviously lots of insight and information that all of you have that you don't have, which has been evidenced this morning. We're learning a lot from all of you. So the first bucket is functionality. And I'm going to just real quickly go through here and editorialize a little bit, and I'd like to stop there and have a conversation about questions or maybe even other things that this group knows about that we don't. So if we continue to use healthcare.gov, one of the things we know is that for the last couple of years it's worked. And anecdotally, what we hear from people is that it's actually worked pretty well, and that they've seen improvement year over year in that last couple of years for Oregon. Participating insurers have connection to the system, and that's an important point because we have heard from carriers that they're not wildly excited about learning a new state-based system and having to reconfigure their own IT systems. And also, the federal government assumes the effort and risk for improving and enhancing the system. That's not a focus that we in Oregon would have to worry about, and that allows us to spend our time and energy focusing on all of those important things that we talked about this morning. So we can keep our eye on the outreach and marketing ball and all of the partnership work we do rather than worrying about technology. The cons, and they're significant, are that we cannot customize healthcare.gov for our specific needs necessarily. I'm optimistic that healthcare.gov could become more flexible each year, but there's no promises. We don't know for sure. And so I think anyone who's weighing in on this issue needs to really understand that we may or may not be able to do things through healthcare.gov that relate to some of the programs that we're already talking about.
And if I could just interject there, because you just said it, but I want to really reinforce it. That does not mean we can't do those things. It means we can't use the healthcare.gov platform to do them. And if we, in the big global sense, decide to, we are doing COFA, if we're going to do BHP or something like that, we would need to figure out workarounds or other means of getting there. That's a different issue than not being able to do that. And I think there's a little bit of a meme out there that not using our own platform means we can't do basic health plan or something like that. And I want to make sure people understand that's not the case.
The other con is that, and Joel mentioned this morning, kind of modest consumer help tools. Not everybody's sure that they're really effective. We have limited data sharing, and with that was really highlighted this morning in the outreach conversation. We do get information from healthcare.gov, and it's better this year than last, but it's not always on time. It's not always as complex as we'd like it to be, and we certainly can't get the kind of access to the level of data that we're talking about. It's going to be especially important this open enrollment period with all the transition in the marketplace, and that's, we can't call consumers like healthcare.gov can. Plans cannot be removed or reinstated easily or quickly, and this has certainly been an issue last open enrollment. And the same is true for plan data errors. It's a huge workaround for us to work with healthcare.gov to do any of those types of updates. Obviously, we're all enjoying watching this year's presidential election, and healthcare.gov is vulnerable to political shifts, just like everything else in federal government. We also don't have any control over improvements or enhancements, and we don't have any control or input over operational and policy decisions. I really hope that when states begin paying, states like us that are the state-based marketplace using the federal platform, when we begin paying in 17 and 18, that there'll be a user group where we would be able to influence the updates, the improvements, the operational decisions, but that's not been committed to. So, I think I'm optimistic that will happen, but it's not necessarily for sure. So I wanted to stop there and see what kind of discussion, questions people have.
I had a question on the con being vulnerable to political shifts. So is that to say if we had our own state-based marketplace that it wouldn't be as vulnerable to political shifts because we'd be in a position to continue that on our own at a state level?
Exactly. So the state legislature could decide to continue having a marketplace or an exchange function regardless of what the federal government.
Yeah, it's a potential, though. I mean, it's nothing like we would know that we would be in a financial position to be able to continue something like this. So it's still really yes.
Yeah, you said not as vulnerable, and that really
right, but
is
still is. Okay, but still would be, I would assume.
You still get subsidies to be able to fund the programs.
Correct.
Yeah. Okay. Yeah.
So the interface issue is not insignificant. As a company that operates in 3 states, and you've got the federal in Montana, Idaho now they went from federal to state. Having Oregon on a 3rd, it just involves considerable effort to just those interfaces are challenging. It's not the driving factor, but it is a factor that can be of concern to areas like us.
Well, Ken, you're in a great position to answer this, and this is something we have not been able to wrap our heads around. What kind of a lift is it for carriers to reconfigure for a new system?
It's pretty significant, and I can't give you the specifics, but I can tell you that it is something that it's significant enough we would plug it into our planning to make sure we have resources allocated. So that says to me it's more than trivial.
And you would probably want or need 12 to 24 months minimum to really make those kind of changes. Yes. And that's one thing that that we factor but not understood as much as we should. But we definitely understand it's not we're going to switch 3 buttons and we'll be ready for you. So.
Question, do you feel like a change to the technology would have more of the large carriers deciding to not participate in future year markets?
I don't think that's going to be the driving factor. It's going to determine whether people are in the market.
Okay. Would it be a tipping point? I mean, potentially, or not as significant as?
Okay. I don't think so. Yeah, there are factors, obviously, like can we make money or at least meet margin, and that's 99% of deciding whether or not to be in or out.
Okay.
On the other hand, a carrier that was going to leave anyway might decide to blame it on that.
Right. Yes, I kind of went there.
Yeah.
That's not what she asked, but yes.
So it's still really continuing with the same functionality discussion, but just these are the pros and cons of switching to their platform. We do believe, that the basic functionality would be met. We do believe the customization would be possible, that Oregon could prioritize and pursue different improvements and enhancements. We have direct access to data, operational control, just obviously all of the converses of the others. So I think the cons probably more significant, not necessarily more significant, but new information here. There are always risks and issues of bugs when implementing or customizing technology. I probably don't need to tell this group that, but I want it on the record that we've said it out loud. Again, the insurer issue. Again, we're responsible for risks. I think one thing we haven't talked about yet is that we would then, as a state, be dependent upon whatever vendor we chose, and really want to feel confident that they have a future and that they're in it for the long haul. And of course, I think another big issue for us, which is a con, is that we're really concerned about consumers, insurance, agents, all those people who feel confident, reasonably confident, I don't want to put words in people's mouths with healthcare.gov, and then having to actually get access to another system when we're not entirely sure that the credibility is 100% there yet in terms of just the notion of the marketplace generally. So we also think we could lose enrollment through a transition because of either people not having the information to go to get a different system, or not wanting to, just being kind of not yet another change. So that's another area of concern. I'll stop there for more questions and conversation.
One other factor is maybe a flip side of the political piece, but without getting bought into Cover Oregon, I think one of the challenges with Cover Oregon was about scope, because you have a lot of input into the requirements, and those requirements grow dramatically. One of the bad things about the federal exchange is we didn't have input. One of the good things is that made it pretty simple. So I mean that cuts both ways, and the more you're building lots and lots of functionality and having trouble setting priorities, the less you're able to focus on let's get people enrolled, let's get their subsidies, let's transfer that information to the health plans, and making sure that those basic things work really well. And that was, I think, one of the challenges.
Absolutely. Absolutely.
So do you think that people would actually have more trust in a state-based system? I mean, could it go the other way?
Well, you guys, I actually asked, I think the folks who work day-to-day with consumers can probably answer that better.
But I know how some people feel about the federal government having control.
It's a good question. What do you guys think?
There's some differences. Best comparison is the Oregon Health Authority of Medicaid. So the call center has shorter hold times for the marketplace. I tend to get less reliable customer service out of the marketplace compared to the Oregon Health Authority. You get more reliable answers out of them. It takes a lot longer to get in touch with them. There are pros and cons to both systems. I don't necessarily think one's more trustworthy inherently. My one concern is that they're rolling out a new one system for the Oregon Health Plan side of things, which eventually wants to start adding back in food stamps and other programs, and to communicate better with the healthcare, but you're the federal side of this, it said that this plan going forward doesn't necessarily one compatibility, so I don't know, by the time we implement this, they might be trying to push for a one compatible system as well, which at least be considering that potential future avenue that is going to be pushed forward in a few years. I don't know if we want to be able to at least choose one of these systems that would be able to be expanded in that direction if we're going to choose a state-based system.
So that's a great point, and that is that the vendors do believe that they did their pricing based upon being compatible or linking up to the Oregon's One system. We're concerned that they did not necessarily really budget for that they may not understand the complexity of that. And so I think that's a risk, right?
But the plan is to be compatible, or at least have them take that on in the future. So it's within the realm of possibility, even if it takes more time.
Right. And I think to your other point, Paul, it's an important one to consider, which is that one is new, one could be evolving, and it could be now that is the best time to link up with them. It could be that's a better time in the future. It could be that it's never a good time, but it's probably an iterative conversation.
Hopefully this doesn't get too far into the weeds or flowers, depending on your point of view. But it might be useful to kind of think about what these are from a technology standpoint. The one system took a custom-built product for Kentucky, brought it here, and almost re-custom built it to meet Oregon's needs. And in particular, in doing that, abandoned the custom-built stuff for the qualified health plan market that Kentucky had did to meet Kentucky's needs. And so you've got this product that was this, and they've taken the Medicaid part and done this. And so to hook back up, you've basically got to do some kind of a bring all that back up, and it's a custom software project, right? That's why OHA spent $60 million on successfully delivering that product. What we've asked the marketplace to show us is kind of like that, but different, in that they're taking their custom-built solutions for other states that are now beginning to be usable across more than one state platform. It's not quite an off-the-shelf market, but it's beginning to turn into an off-the-shelf market. And we're asking them to show us that proven technology and show how we would use it. And so to move forward down that path, we would be having a little bit different kind of a conversation at some point in the future if we were to fully marry up with the one system. And it would be a question of, do you take if we move down this path, do you take what we chose to do and figure out how to hook it up with one, or is it more cost effective to make those investments to do that leveling up of one to make it function on both sides? That may be like mind-blowingly complicated, I know, but that's kind of the state of the different technology. Versus, of course, the third one, which is stay on the federal platform and deal with one integration out of whole cloth later.
Can I find something? So if the decision is to go forward with the Oregon solution, with the separate solution, there's going to be more conversations with the vendors, existing responsive vendors, and possibly new ones. And I know there's been internal discussions about including this relationship between OHA and the marketplace in those discussions. So I think it goes to your point.
Hello, this is Maria. Can you guys hear me?
Yeah.
Maria?
Hi, yes.
Just hang on for just a minute. Our DOJ attorney is talking, and then we'll toss the phone to you.
I'm talking.
Okay, thank you.
Laura is a participant in the project. Sure, the whole ride. But what I was saying is, if the decision is to go forward with an Oregon solution, there's going to be further conversations with the vendor community, and internal discussions on the team have included the idea that we need to have a more detailed conversation with the vendors about the relationship between the marketplace and OHA. And it goes to Derek's earlier point that we aren't solid. We aren't sure that the costs are solid. That's one of the variables in the cost that the vendors may not have understood and built into the proposals.
Yeah, there's a little bit of a chicken and egg. You don't want to go too far with the vendors and get too specific about the price, but you also have to make some high-level judgments. Maria, go ahead and jump in, please.
Great, thank you. So having used multiple platforms. I mean, we currently use the Idaho one, we've used the Cover Oregon one, and healthcare.gov has definitely worked the best out of all of the systems. And even the one system really makes me wary about jumping into new technology. For example, our assisters are still waiting for an email link that is the only way to create an account with the one system to be able to assist people. There's no other way, apparently, to create an account without this link that supposedly has been emailed, but we still haven't received it. We've been waiting for months for it, and we've heard stories from other community health centers that are also having trouble with the one system. So I would just caution everybody to really think about jumping into a new technology platform, especially when one like healthcare.gov is working so well. I definitely see the cons, but it is getting people enrolled, and just something to really consider.
Furthermore, I don't think the one is customizable as it was initially thought of. We've had some difficulties getting you still qualify based on monthly income, or you still qualify based on monthly income for Oregon Health Authority, but if your yearly income was below a certain level of the FPL, you can qualify and get onto medical benefits through that. One system does not allow that whatsoever, so they've had to actually change the policy and stop allowing people. This has impacted a lot of people with seasonal wages or migrant laborers and other situations. So there still are going to be difficulties taking a system from another state like you did with one system and trying to change it to our policies. It's not going to be completely free to customize.
Really quickly, and I think you touched on it, Barry, is there, the healthcare.gov seems to work fine for enrollment, that you can click through, get enrolled pretty seamlessly, actually. The issue, as I see it, is on the front end, shopping, and on the back side, just completely disconnected from anything. Is there a hybrid, a way to do a hybrid system that you still do enrollment through healthcare.gov?
I think there's a way that we in Oregon could improve the tools on our website, because we already really push people to both websites, but we've already created this infrastructure of resource and help on OregonHealthcare.gov, because that's where we want people to go if they need local help, if they need information. And I know, for example, this year we built our own kind of resource and referral tool, because we think it'll be much better in terms of not only finding local help in communities and being tied to our agent storefront program and being tied to the community partner program, but it's also going to have a system where you can enter the language you need, and you can find people in your area who can help you by language. So some of those things we're really trying to focus on. So I don't think we can't necessarily increase the plan selection process, because that still needs to be on the enrollment end, but I think there's other consumer things that we could have on our website that would be helpful. And then on the back end...
Sorry, go ahead. This is Jesse, and I was just going to say that there are, I don't want to necessarily endorse any of these tools without doing some more due diligence, but there are some consumer shopping tools that have been created as sort of wraparounds for healthcare.gov, that if we do decide to keep healthcare.gov as the primary enrollment engine, we might want to at least take a look at, that can provide people with some more information and more easily usable information about their out-of-pocket costs and quality of care and some other things. I think they might be worth looking at. I know, Barry, we communicated a little bit via email about one of those a while back, but I think there's a couple of other ones as well.
Definitely. So I think there are things we can do to bring that level of service to Oregonians. The other thing you mentioned is there's a back-end issue, which we've become increasingly concerned about, and that is that when people are just a straightforward enrollment case, it's fine, it works really well. When people have any kind of needing to problem solve or things that are strange with their account, healthcare.gov's customer service center isn't really the best resource. They have a tough time doing anything that's real particular. And so that's really highlighted for us the huge importance of having our team, because our team understands insurance, they understand enrollment and eligibility, And so what they do is they act as that advocate for Oregonians and working with healthcare.gov, and that has been unbelievably necessary. And we're also pushing on the healthcare.gov administration to really, we want someone at the FFM who will actually help, be our point of contact so that we can more quickly get our consumers assisted. And again, back to that user group idea, if we're now paying for the system, we want more influence over how decisions are made and how you manage your call center. So there's a lot of room for improvement there.
I guess I'm just thinking about it. I enrolled seamlessly. I mean, clicked, and okay, it went through. But then I guess I would have never called healthcare.gov because now it was with my insurer, and healthcare.gov didn't even know that anything was happening with the insurer. So they would have been lost. That was a successful transaction with healthcare.gov, but I wouldn't have even thought of going to them on the back side, or I'm not sure what I'd go to them for.
So I can jump in on this one. So Cindy, what I've discovered pretty much consistently is when we're talking to the carriers about an FFM enrollment, marketplace enrollment, excuse me, they pretty much turn you back over to the marketplace. They don't even, because it's the marketplace that tells the carrier what the subsidy is going to be, what the premium is going to be, et cetera, et cetera. So with regard to any problems that happen with the enrollment, I kind of get back and forth. Sometimes we get the marketplace saying you need to go to the carrier. Sometimes, and we just get looped back and forth. So my clients who have attempted, because they're getting all these messages about you've got to fulfill this requirement, you've got to do this, vaguely threatening messages, some in multiple contact formats. They're getting the mail, they're getting calls, they're getting email like crazy. So I have people come to me saying, what do I do, what do I do? So a big part of my world is reassuring people and saying, come and talk to me, don't even go to healthcare.gov, because most of the time, at least 80% of the time this year, not so much last year, they get incorrect or misleading or contradictory information. So the customer service piece is horrible. Yeah. I would much rather talk with the carriers, to be honest, with their customer service people, because they're far superior to anybody that's at the marketplace.
But if there was a problem with enrollment, we don't have that data.
Yeah.
We don't know that person is there.
Right.
So.
Yeah. Exactly. We don't have that information. So, a big part of what we do is problem solving. Serving as that intermediate.
And to echo that, I mean, I can say that all customer service, whether it's OHA, whether it's Your Health Idaho, there's definitely that trouble and that passing people along to, well, we can't help with this, you need to call them. So, I mean, that's something I've seen even with Cover Oregon. I've just seen that throughout every system I've worked with. So I appreciate the goals of that being improved if we have our own system, but I haven't seen it yet.
Yeah, I would say
that's a great point, because I like to think, well, we were managing the call center, they do the best. Every Oregonian will serve, and I want to think that, but if you start having technology problems, then your wait times go up, and then you're having to hire a bunch of temps because your call volume goes up, and you have less control over the employees. I can see how it happens.
I have a question. On the pros, Oregon would be able to maintain control, but would that then unfortunately detract from DCBS's other goals and kind of put what our goals are for this year on the back burner? I don't know how much cost plays into it or how much scrutiny there would also be to any cost associated with the new platform program. And if then we'd be kind of in the dark, this 2016 year, as all the emphasis and focus would be shifted towards 2017.
That's a great question.
And that's scary.
There's a bandwidth question there for sure.
Right.
Yeah. I think it's a huge concern. Should we move on to cost? Dan's giving me the eagle eye. This is, I think, a shorter, more straightforward. You continue to use healthcare.gov. We know what the costs are, and those are elaborated in the analysis. It's about $31 million a year. Switching to another platform is about $34 million per year, so it's about $3 million more. Again, the con on the healthcare.gov in terms of cost is that the federal government could increase fees in future years, although much like our rulemaking processes, we always have an opportunity to provide input. So the con of switching in terms of cost is that there is the $34 million a year covers what we've asked them related to the RFP. It doesn't cover other customizations that people want to see in Oregon. So a basic health plan, anything else would be at other costs, and it's helpful for me to know that those are in the millions of dollars. As I learned last, well, you all do that. I did not realize that any technology upgrade is millions of dollars at that kind of level. So it's not a couple $100,000. And of course, there's always the risk that the actual implementation costs could be higher than we predict. So discussion about costs?
Just a point about that one. That's a big enough question. It's what John touched on earlier. That if the recommendations from everybody were, yeah, we should go forward with doing our own platform, I would say that we would need to do a period of negotiation and evaluation with the vendors and almost come back and completely re-answer that question once we had done enough technical evaluation and back and forth with them to get from what I would consider like a 60% number to a 90% certain number. And it may be that these numbers would be so dramatically different that they might lead to a different conclusion than you'd be able to make now.
I have a question for the cost. So if we did decide to proceed with the state-based marketplace and we signed contracts and got to that piece and there was a political shift that unfortunately made this all fall apart, we'd lose that money, essentially. Whereas if we stuck with the federal technology for Plan Year 17 and there was a political shift that undid this, would we be tied into that money still, or we wouldn't be at that point, right?
It's more a variable cost, right? So it's pay as you go.
Yeah, so we wouldn't lose the money in a political shift with federal, but potentially would on a state-based marketplace. So if we spent millions of dollars implementing the program and the next government decided they don't want to see a state-based platform, or the head of our country, the presidential election, and this thing comes undone for 2017. I mean,
I'm sure President Trump would be very fair.
Right.
I think it would be accurate to say if there was a truly dramatic political landscape shift at either the state or the federal level, there are significant cost risks that would go with either of these choices that would almost be impossible to kind of game out. I think the chance of there being a huge political shift, I mean, understand, Oregon is fairly blessed in most of this enterprise that we're engaged in. There's a bipartisan consensus around it, and it's not sort of a partisan political football. And so it's hard to imagine what a big enough political shift at the state level would be to cause us to dramatically rethink everything. It's relatively easy at the federal level to imagine what that might look like.
Right. Okay. So no clear way to say that we would definitely be out the money if we did the state-based, or not out the money on the federal base.
Well, I think this is part of your question, but proposers proposed in different ways. So some of these costs are.
I'm writing the mic, please.
I think this is related to what you asked, but proposers proposed in different ways, and their costs are made up, depending on the proposer, or a combination of operational costs, what's it cost to go, and implementation costs, which are kind of costs that you don't get back.
Right.
The operational costs are the kind of costs that you never occur.
Okay.
So each proposer provided a different mix of fixed and operational costs, so that sort of plays in the answer.
One quick question. I see this kind of like an HOA, I guess. I've never been a part of an HOA, but as I understand them. So those of you with experience with other states using healthcare.gov, is there a movement away from healthcare.gov? Because it seems as people would pull away from it, those costs are likely to increase?
I don't think so. I think in Idaho's case, they wanted to do their own exchange to begin with and didn't feel they could do it in the timeline, so they did it after the fact. The other state where we do business is Montana, and they don't want to go near doing their own exchange. I just don't see other folks making that investment. That's my own bias. I don't know if Eric, you have a different view.
No, I think you're exactly right. What we've seen is there are more state-based exchanges using their own systems now who are being pressured or feeling like they need to investigate going to healthcare.gov versus states that are using healthcare.gov that are exploring their own technology.
So Barry, I know it's totally unfair to ask you to predict the future, but
we're going to.
I'm going to do it anyway. One of the things that I'm curious, I couldn't really get a good feel for in all of this, and given just what you and Ken have said in particular in response to Cindy's question, I'm curious to know what the future of healthcare.gov is and what functionality they plan to bring, and especially if more states wanted that platform, maybe some larger states. I suppose California never will, but there is a critical mass because really the big limitation for us is the flexibility and the functionality. And of course, the bigger they get, the more money they have coming in, the more states run that platform, the more incentive there is to provide functionality and the flexibility, because as we look at a lot of the cons, that's really what it is.
I tend to be an optimistic person by nature, which doesn't always serve me well, but I do think that they have gotten better. I don't think they, from my perception, Ken, you probably know better than I do, I don't think they thought they were going to be in this huge business of providing a big national...
It was a backstop originally.
It was a backstop, and so then all of a sudden they were in the position of having to be the primary system, and they've gotten better as a result. And so I think they will just continue to improve. So that really is my prediction. But of course, there is a lot of unknowns in the next 12 months.
Yeah, and we can't bank on the unknown. But the other thing is, I do think we need to be accountable for the long haul and not making decisions one year over the next. And so, if we think, for example, that other states are looking, or if CMS has started to signal, hey, we're looking at this, we're looking at that. That's just helpful for us to factor into our thinking.
Well, there's a lot going on in the market now, too. We kind of foreshadowed that in earlier conversations, and all of that will play into the discussions about technology and systems, et cetera. So there's just a lot of change going on, and all of that will impact an analysis of this decision now and an analysis of this decision 12 months ago, because deciding either way, deciding to stay with healthcare.gov does not foreclose having this conversation again 12 to 24 months from now.
Yeah, if you think about a more negative view, probably one of the things to watch to me early on in the new administration would be, I think repeal will be really hard. That's my own bias. But taking pot shots at things might be pretty easy. So if you do things to defund or you do, right. So that'll be what we'll have to watch, is whether there's actions that kind of weaken healthcare.gov instead of.
Yeah, I'm not being wildly improved by saying that the whole risk corridor thing was an intentional effort at sabotage of the system. I think that's still potentially a tool.
So I have to say one thing that disappointed me was that there was not an opportunity for a significant cost saving. Because, I felt this way from the time the ACA passed. 3% of premium is not insignificant. When you think about, there's not a whole lot of things administratively that are costing 3% of premium. I don't know, dance costs are even lower than ours, but our total internal stuff is 7 to 8%. So 3% is a big chunk. There's a lot of things that add on top of that with commissions and taxes and all sorts of things. But it was disappointing that we couldn't justify it from a cost standpoint.
It was surprising too.
Yeah.
I was really surprised. Okay, so we'll move on to program impact. Actually, we can do this really quickly because we've already talked about a lot of these things, so I'm only going to highlight those things we haven't discussed. So I think, let's see, just to kind of re-highlight, there are a couple cons in continuing to use healthcare that we haven't really talked about. Joel mentioned it earlier. We don't have any control over kind of national advertising or that direct contact with consumers. And we also don't have any control over the agent certification process, which may not be a con necessarily, it can kind of be how you look at it, but there's less of that kind of control with, not agent regulation isn't the right word, but maybe that relationship with agents. So we've kind of created a different avenue for doing that through the storefront program and newsletters and things like that, but there's not the same direct relationship you have when you have your own system and have that kind of plan in place. So then moving on to another platform, I'm just going to scroll through here and see if there's anything we haven't really talked about related to programming impact. I think presumably a pro, and I think it's worth repeating, is that we would have better call center service and maybe just better issue resolution, because that is a real area of concern right now. It feels like it almost, to be honest with you, is getting increasingly concerning.
Terry, as we think about what I would just label these generally the cons as what a distraction factor.
Yeah.
And you've highlighted IT, but I'm really thinking about Joe's comment. And I think a lot of us around the table are passionate about getting past health insurance and access to health. And that, of course, was the original vision in Oregon. And I think a lot of us are intent on recapturing that vision. And so there's a distraction when you're focused on technology platforms from really saying, okay, we kind of have the access piece, at least on a path for now. How do we start to dig down beneath that and look at specific parts of the state, specific ethnic and racial communities, and think about what it means to be healthy, sort of what I asked the tribes. And I know probably some of us feel like we're still a ways from that in the context of this, but that is the vision. We want to get there. And so I don't know that that needs to be added to the con, but I'm sure there's plenty of legislators, who are more passionate or less interested in platform, more interested in how do I get my constituents healthier. And so I think that's important for us as a state to be able to recapture that vision and get ourselves on that path again.
Yeah,
that's a great point. Yeah, because in the legislation, it calls for hospitals to do a community health assessment, and it's so what if you're not thinking about health of the community, then it just becomes a benchmark and not anything that really striving goals for the entire community, but instead just saying how do we deliver service in a healthcare setting. And I think that's a great point, is to really take a step back and say how do we engage and use this process to make our communities healthier or our state healthier as a result. Given that we've all, or at least nonprofits, have been required to do that community health assessment, because now you have that tool that you can.
What do you do with it?
Yeah, what do you do with it?
So one way to look at it is maybe the biggest gift that the marketplace can give to the people of Oregon is stabilize the platform, create an access path, and allow the state collectively, from the legislature and the governor on down to all of us and individual communities, to return to that discussion. How do we use those needs assessments and those findings to really drive health? So
I think also, just to bring it, I know that you're doing a good job in looking at what's happening in other states, really collecting more information so that we make informed decisions. Also, really seeing what's happened with a state that went from, a healthcare.gov platform to that platform, and see, well, what has been the result of that, in terms of how it's impacted consumers as well. So not just, you're right, not just looking at the cost and the cost-benefit analysis and the risk factors there, but also really looking at, well, how effective and how impactful has that been for our consumers. That's an important conversation.
Yeah, and I think what's interesting is right now you have, my position focused really on things like faith-based outreach and how to do a storefront program that's focusing on getting languages, multiple languages out there. If we're doing this, I'd be begging for somebody responsible for the technology, but you just naturally lose that focus because it comes to the priority and the deadlines. And I think one of the reasons I was surprised that we were able to get a campaign done as well as we did is that we were all just completely on it. That it was our just complete focus, and that intentionality is just huge. So, anybody from the phones want to chime in here about program impact or anything else?
This is Jim.
Go ahead, Jim.
So, my perspective is that if we thought that what we had created between our program and healthcare.gov was essentially the package that we wanted, and all we needed to do was fine-tune it and see what impact we might have on making small improvements, innovations with healthcare.gov, then that probably would be the best value for the dollar we were going to get. But it seems to me we have a long way to go in terms of kind of bending the curve and improving health delivery and health care in addition to access. And all of those kinds of innovations and things like SHOP and COFA and basic health and family glitch and all of that, I think those innovations are going to come from models created at the state level, rather than that healthcare.gov is going to start experimenting and stepping out and making those kinds of changes. I don't see that typically happening at the federal level. And so we do need to be cautious, but I think that any way that we can move more of the control and the potential for innovation to the state level, the better chances we're going to have to make a significant impact in the long term. And so I would like to hear more about the individual proposals that have been sent forth, but that's still, I think my take on it is that I'm much more inclined to try to go with the bringing in a contractor to put together a more Oregon-centered plan.
Jim, people were listening intently, and I appreciate you bringing forward that perspective. If people want to respond to that?
Dan,
Yeah.
if I could just say, I really appreciate some of the comments, and I appreciate the point that you made about where we want our focus to be, and currently assisting in a state that did transition from healthcare.gov to their own system. I can tell you they're still having problems, and agents are not happy at all. Consumers have had so many problems, and yes, they're getting better. This is going to be their third open enrollment, but there's just, they've lost the focus that we were just talking about having, reaching out to the multicultural and multilingual communities and really impacting health. It's about getting the technology to work, and I would hope that we would take all of that into consideration.
And I have
Shannon, thank you, on the phone.
A comment. So it seems that what we'll potentially lose if we move to a state-based system would be some real dedicated outreach and I guess just focus on our underserved populations. However, implementing our state-based system will allow the system to more adequately help those individuals. So if anybody has any insight, would those individuals be better helped with face-to-face one-on-one, or is it better to get the technology online so they can do it themselves? Because those are...
I can speak some of that to the COPA enrollment process. You're going to have to fill out a Oregon health plan application, get denied, then go on to the federal marketplace, sign up for a silver plan by yourself without any changes to the healthcare.gov site, know to get onto a silver plan, and then go get onto the payment assistance program. So it would be a significantly simpler application process for people in that situation if we can get that state-based exchange. The issue would take a couple of years to put that up. It's probably not going to work that well the first year. We're implementing COPA this year anyway, so no matter what, we're going through the first year of COPA applicants are going to be through the health insurance marketplace. So at least for the next couple of years, we've kind of committed to some degree to go doing the direct outreach role. Other states are innovating on the technology point. They may have better solutions available as far as a couple of years. I don't know. I definitely support going towards a state-based system. I'm not sure we've got far enough on the technology front in other states. I'd like to see states where that works well before we take it on, rather than trying to make that feel when we've already got things we are innovating on that we can lead the rest of the country on the COPA. I think we're already doing that. I feel like we might be setting ourselves back on initiatives that we're already moving on, but we can take up the state-based exchange at a later year without hampering us.
The potential from a clinical perspective that I saw when I read through this was potential of health information sharing through the same system, the same platform we have. So I know out where we live, sharing health information when we transfer patients to Portland or Eugene, and they're a trauma patient and they can't speak to us and we don't have any information at all, to have that, and it may be too futuristic thinking right now, but eventually that could be a potential that would help everybody in the state.
So Barry, getting some good feedback. It's a complicated issue. Keep us moving because I do want to try and get, at a minimum, get a sense of where we are for this year. I think something to remember, particularly in light of Jim's comments and Sean's comments. We're hearing you loud and clear. This is an issue that we're not going to be done with. It's not a one-time deal. So we're really thinking about, in the context of this coming year, what do we want to recommend? But let's have you keep this going, and then we'll have some additional discussion before we close.
I think we've really already touched on most of the things that are of consumer impact. The pros of healthcare.gov, consumers are familiar with us. They find value in the platform. The cons that doesn't always work well for all of them in special circumstances. And then consumers continue to be confused about wanting to contact the state versus the federal government. Even though we've been using it for 2 years, there's still a lot of confusion. And I always like to remind myself and others that even though a lot of my entire role is the health insurance marketplace, for consumers, we're just, one of the many things that they're dealing with all the time. So we're not the center of their world. Switching to their platform, a new platform may better serve Oregonians. They'd only have one website related to Oregon's marketplace instead of 2. Cons, they would have to relearn where to go. All of our partners would have to relearn. Auto re-enrollment would probably not be an option the first year, so everyone's signing up again for the first time, which obviously increases the risk of people avoiding the system, that enrollment could decrease, and of course that we could have another year of system bugs or issues that could erode trust in an already, I think, fragile credibility relationship with consumers and our partners.
Barry, I would just ask you to think about, as we continue to use these slides going forward, the point that Sean made about COFA enrollment potentially, again, not in the first year, but potentially could be streamlined if we were effective with our use of technology with the state. And then Jim's comment and others, that there are some longer-term pros that I think we all want to keep in mind. We don't see those right in front of us for 2017 or 2018, I should say, but they are longer-term pros of a state-based for the consumers.
Absolutely. So Pat mentioned the next steps earlier, that this group is really advising him to really take forth your findings, recommendations to the legislature in May, and that's it. So there probably is other discussion or questions, but that's it for the formal PowerPoint.
I want to thank you and the team for the great work you did on preparing this in pretty short order on state time, pretty quick.
Wait a minute. Wait a minute.
I come from a big bureaucracy, so I can say that. It's no, we appreciate the good work in short order to get it in front of this committee. We know the legislature has Pat and Barry on the hot seat, and we want to help you get back to the legislature with our best possible thinking as of today. So with that, let me throw the floor open for one last kind of round-robin discussion. Where are people feeling, based on this presentation, based on the reading of the materials, if you were, if Governor Brown called you on your ride home back to wherever you're headed and said, what do you really think we should do? What would your advice to her be?
This is Jesse. Can I jump in?
Yes.
So this is a somewhat agonizing decision for me personally because I really care deeply about having the kind of state flexibility to do innovative things with the marketplace that we've all talked about, and that Jim, I think, talked about really eloquently a minute ago. And I think for the long term, finding some way to achieve that flexibility should be part of our goal for the marketplace. But I just don't think that I can, in good conscience, support switching from a system that is working today, albeit not as well as we might like, but working when the case for switching and the options that are available are just not a complete slam dunk. If it costs significantly less to go with a private vendor, or if it was really clear that we could avoid some of the potential downsides, then it would be a different situation. But I just think that I think it was really important that we looked into these options, and I don't think that by deciding not to switch to the system right away, we are foreclosing doing that at some point in the future. But I can't, in good conscience, recommend that we make the switch right now, personally.
Shannon.
I have a comment, just kind of thinking on the same road, like we could potentially do this later. However, the open enrollment period's getting dramatically shorter for plan year 18, and so there'd be no way, I don't think realistically, we could cut our enrollment time in half and implement a new system. So it unfortunately is almost like, seems now or never, really, to those of us who assist. I mean, can you imagine re-enrolling every single person in half the time on a new system?
Not without hiring a bunch of people at the same time. I also retraining everyone for a new system is going to remove outreach for that year essentially as well. So I don't know, you're losing a good portion of our work either.
Right.
I don't.
That's a huge comment that we didn't even think about.
Yeah.
That changing open enrollment period in a couple of years and how. So that's why you're here. Yeah, I thought about that.
So that I would potentially say let's postpone it because I don't know that now is the best time. But then with that, that's a worse time, really. I would say, you know.
It really isn't a good time, as I see it.
Well, but I want to make sure I'm following. If we were today to decide to move forward with a platform, we'd be talking about the 18 enrollment year anyway.
Oh, really?
Sometimes that's the very soon.
Oh, you're
that's
right.
the very
It
soonest
would be
we could do.
18. So then I would vote definitely not. Yeah, we can't. My years are mixed up. Sorry. Yeah.
I would say actually it's that.
Yeah, I would say, yeah. Ooh.
Yeah, between now and fall would be a tough tall order.
Yeah, it would be right. Right. Yeah. That's.
Boy, this is like Jesse. I've had a lot of agony and agonizing over this very issue. My inclination is to want more functionality because I see so many problems day to day, every day. On the other hand, in looking at what the future is going to bring, Dan, your point is really not lost on me. That there are advantages in the future that we may not see in 2018. But in 2022, we may see some dramatic advantages by having a state-based system. So while I understand that we don't want to lose any more trust and we don't want to spend the money, we never want to spend the money. Let's just give that, the carriers don't necessarily want to recreate their technology. But in the end, I think I'm in favor of it. I'm in favor of a state-based system. And I don't know that that means to do it immediately or to get started immediately and implement as in 2019 or something, but I am inclined to say let's bring back the control, let's bring back the customer service, let's bring back the information that we need to really support. And yes, we may lose a bit of outreach, but we're going to come right back and we'll recover, we'll learn the new systems, because we will do that. That's what we've all committed to do that's here, in this committee and in our state. So, people are going to fuss about it because people don't like change, but in the end, I think it is to our advantage.
I want to make sure everybody has a chance, whether they want to or not, to weigh in. So let's just keep going around. Let people, when they feel moved, Claire.
I guess I'm just curious, what is the time frame we're actually talking about as far as a recommendation? We could make a recommendation to do this in 4 years, but so I'm not quite sure.
Yeah, so that's a great. I was just thinking about that very same issue. We need a recommendation about what to do now, and now means going to the legislature and saying we believe we should pursue this now or we should not pursue this now. And then there's a whole bunch of things that line up around that, coming back to them with a budget package and all those kinds of things, continuing our evaluation of the vendor proposals, probably doing some things. There are some procedural issues around that to get that all squared up, and then an actual decision and managing a project and all that stuff. And so we need that. Ideally, we would get it from you today. What should we do now? Now, hearing a couple of comments, it's certainly kosher for you guys to say something like, we think ultimately you should do this, but where we are right now means you should do that. Okay? And having some tension between long-term and short-term is, from my standpoint, is a perfectly workable workable recommendation that gives us an idea of where we should be thinking about being long-term, but we may be in a different place short-term.
Claire, does that answer your question?
It does, you know, because I keep thinking about the one system and like kind of want to get through that before we start down this next potential thing. And I do feel that pull towards a state-based longer term, but not right now.
We can see what we learned from COFA and PHP first, and then integrate it better with those systems if we had maybe a year or two of data from those programs before we design the system around it. So there might be further savings. I mean, what you were getting at is there's a parable about two men in a river, then a bunch of babies coming down the river. They're trying to pluck them all out of the river. One of them leaves, heads upstream. The other asks why he's doing that. Well, we go find out whoever's putting the babies in the river. So we have to, at some point, capture both of these. We need to address the problem, which is what the state-based exchange attempts to do, is give us the flexibility. At the same time, we also have to keep the people who are currently dependent on getting their enrollment process well every year and not dropping those people. And we're kind of choosing between future returns of people who can't help and people who are dropping this year. So.
And thank you for the weirdest parable.
But you'll never forget it.
So it's the upstream, downstream. Who are we getting on each side? I don't know.
I heard the same parable, but it was health insurance executives. Nobody was pulling him over.
All right, Joe. I like your comment, Pat. That is, ultimately, I'm supportive of going to our own system in Oregon. I think that if something's important, you should take control of it. That's always been my philosophy. You shouldn't be dependent on others. I don't think we get the type of information that Oregon and Oregon consumers want in order to make our systems and our plans deliver what we want when you're counting on a federal system to give us data. I think if you go back to earlier in the presentation when you talked about your 3 strategic goals, and there was some emphasis on multicultural, some emphasis on other populations, you're not going to get that using the federal exchange. You're not going to get the data that you really want using that. So ultimately, I think if those are really your strategic goals and really what you want to do, you're not going to do it with the current format you have now, unless you're counting on a user group down the line that then starts to customize it. But then that's even further down the line if you decided to pursue your own state system. So ultimately, I'd like to see us have our own system. I also heard you earlier saying that you may come back with more numbers after you flush that out. We may change our minds after that. I totally understand that, and that's the direction I would like to go, is to have more information to be able to say, yeah, this is a green light from us.
Yeah, let me be clear. The more information and new numbers would be, if you were all to tell us today, go forward, you think we should pursue a platform now. And if the legislature later in May concurred with that, and those were our instructions, were right now go pursue these bids, we would go through a period of examining these bids and refining those dollar amounts, and we might say, oh, hang on, it's actually going to cost $20 million more to do our own than not. If the recommendation from you all today and from the legislature later in the month is eventually yes, but not now, then we're not going to pursue that with these bids and not have that information. I just want to be clear about that.
I'm not changing my stance. I still think it should go forward now, and then.
Oh, go forward now. Got it.
Yeah, go forward now, and then as we get more information, you have to modify to the information.
Got it. Okay.
So.
Got it.
Yeah. You were saying go forward with the state-based exchange.
Yes.
Ken, Laura, Cindy, Maria, Jim, Mark, if you're still with us.
This is Cindy. Go ahead. Somebody on the phone? Okay, I'll go ahead. This is Cindy. I would be opposed. Kate, this is Cindy. I'd be opposed to moving forward with a state-based plan, not because I wouldn't eventually like to see it, but I think Cover Oregon is far too fresh in people's minds. I think some of us tend to forget that we are still so early in the process of healthcare.gov. Healthcare.gov will improve, and I would like to study further or look at further what COFA does, and kind of that's what I was thinking about with a hybrid, could we do hybrid systems? And I would like more money to be spent, or any money that's out there, to be spent sooner on healthcare outcome. What we were talking about earlier is that there's data out there for the health of the population as opposed to access to health care. So I would want to start spending money on that, on producing that for a website to add to what we've got already with the and so I would continue to use or vote in favor of continuing to use healthcare.gov just because I think it will get better, and let's make our modules, Oregon-specific modules here and have the code.
Dan, I don't know.
Hi, this is Maria.
Go ahead, Maria.
Sorry. Yes, thank you. I completely concur with what Cindy just said, and also echo what Jesse said earlier. I oppose moving forward right now with our own system, and would recommend to continue using healthcare.gov.
Wow, thank you, and you win points for conciseness. At 12:10, I don't mean to rush people. This is very important, but thank you for your clarity, Kent.
Yeah, I agree that I don't think we should move forward right now. I think we might want to frame it like we should revisit in a couple of years. Things are going to change, so I don't think we should put it off, but I think revisit and re-examine. I actually agree, which hasn't happened a lot, but 100% with Jesse's analysis. I mean, completely. The other thing that I would add is that I think right now there may be bigger priorities that the state should focus on, which may be as basic as market viability, and that we should really have our attention on the big picture and make sure that we have a market that works.
Joe?
Yeah, for me, I have a different perspective. I like to see come at it from a consumer perspective, especially, I'm part of the COPA community. Time is of the essence, and I think that that can be lost in some of our conversations. Last month, I'm also a lay pastor, and I had to do 2 funerals for 2 of my community members who were not covered, who did not understand how to get covered, and who were once covered at some point and then dropped off because there was not that ongoing follow-up and updating. And they died of simple things like chronic diseases that just kept on piling up. And people are dying. And I tend to think that we go through trial and error to improve things. I was just reading last month the history of Medicaid and OHP in Oregon. There was a lot of trial, but if we didn't take the risk today, we wouldn't be benefiting from the fruits of all of that. And I know that this is all, risk analysis is a huge, thing. Either you're more preventive, you prevent the fire, or you take a chance, and I believe in Oregon. I believe in, I'm very optimistic, like Barry is. But I think that going through the trial and error will improve our system for the people. And not doing anything right now, and saying we're going to study and study and study, there are people dying as of right now. So I would really strongly recommend that we do something about it. So moving forward with the state-based institutions.
Thank you. Laura, we have Jim and Mark. Again, I don't know, I haven't heard Mark recently, but I think Jim is still with us and has some strong feelings, and Laura as well.
I think it was hard.
This is Jim. And I'll just say,
Jim,
I think.
Jim, hang on just for a minute, Laura. Make sure you're talking right in. Thank you.
So I think the slow but careful planning, I think is what it's going to take without putting consumers at risk for access to care or health care in general. I always think about what's the risk to people. If we just go full bore and do this right now, I think it's going to take away a lot of the focus on the outreach, which I know is lacking in our county. But I'm for the state-based system. I think it needs to be a slow, methodical implementation of planning. But I think in the end it's going to improve quality and care across the continuum of people. When they do transfer or move from an area and they have access to their own healthcare records, which seems to be a big complaint in some areas about people don't know what their medical records are or what those lab results were. Or they don't have the communication channel. I think that would be great, satisfying.
Thank you, Laura. Jim, go ahead and jump in.
Okay, so here, my perspective is still, I have to say I am frustrated to hear that we're still being stymied by private software developers. That's totally frustrating in this era, but I think Oregon is uniquely placed with the kinds of innovations that we've been moving forward with in healthcare models, including delivery of care, all of those sorts of things that are going to be essential to all the states and to the federal program in the long term, because in the long term we need a federal program. But the only way that's going to happen is if states bring forward innovative ideas that Oregon is uniquely placed to demonstrate. And so on that basis, we've heard about one software that isn't working so well. I've not heard that the others are having those problems. I still think that we have a responsibility to be creative and to move forward with the state-based plan. Thank you.
Thank you, Jim. Mark, if you're still on, I want to make sure you have a chance to weigh in.
Thank you very much. No, I think that it's been very, very good to listen and take copious notes. Certainly there was a comment made some time ago about community assister and access for one that I'll follow up on internally. No, I think it's a real healthy conversation. I mean, when you come right down to it, we have a system we've stood it up, and it's hard work, certainly from our standpoint on the Medicaid OHP side, to now get it working and rolling the way that we want it to work in terms of outreach and access and customer experience. But we're getting closer every day, and so I just think it's more important that those of us at the state listen very, very, very hard and listen well.
So I'm going to try and summarize. I'm not going to name names, but I'm going to try and summarize where things stand. And remember, in a situation like this where we have kind of on a path, what I would look for is there really a strong majority of people who want to change the path, and I definitely didn't hear that. What I heard, I'm going to lump people, and this may not accurately capture, but I'm going to lump people in about 3 groups. One, I heard people pretty strongly, starting with Jesse at the top, I did just name a name, I guess, but pretty strongly say, stick with the federal platform. And then I heard a group of people, 3 to 4 folks, who said, I'm really strongly inclined toward the state platform. I'm not ready to put a stake in the ground around that right now. And I call that sort of a delayed move to the state platform. I'm not naming names, but you know who you are. And then I loudly heard a third bucket that said, to do what we want to do for the long term, we need to move directly to the state platform. And again, not naming names, or not even doing numbers, it kind of fell into those 3 buckets. And so what I hear, Pat, is that we probably don't have consensus around one clear strategy, but I can also say, conversely, we don't have a consensus to move to a state platform. And I didn't hear that loud and clear, and I want to just pause there if anybody disagrees with that. Again, I'm just trying to summarize, not my opinion, but the opinion, the consensus of the group. What I did hear, though, as you communicate back to the legislature, is there are a majority of people on the advisory committee that are interested at some point in further exploring the benefits of the state platform, even if they weren't feeling compelled to say, let's do that for the 2018 open enrollment period. But I don't also hear that we're able to make a recommendation today that we think the legislature should move to the state platform for 2018. So let me take a breath, tried to roll, a bunch of really, and I appreciate everybody weighing in with strong opinions. I think everybody had a point of view, which is fabulous.
Let me ask a clarifying question, because you can imagine I'm going to work pretty hard to get you to make a recommendation today. This is a question to the people who self-identify as being in your first bucket. If the statement were that the advisory committee recommends moving to a state-based platform, but that doing so at this time, but doesn't recommend doing so at this time, how many people who are in that first bucket would find themselves in that second bucket?
So I'm going to look at Jesse, Shannon, Ken,
here come the names,
and Cindy. Just out of the blue, I'll pick those 4 people. Give us your feedback on Pat's comment.
This is Jesse. If I can go, I would say that I'm not necessarily opposed to that. I feel like I don't want to cast my position as being opposed to moving in the direction of a state-based platform. I just think that the option that's on the table, I'm not convinced that we're in a place where the actual existing state-based option is something I would be comfortable recommending, because it costs more, only a little bit more, but it costs more, and there's a number of risks associated with it. And I'm not convinced, based on the information that we have available, that it wouldn't make a number of things worse. And I feel like I would have to be convinced about that before I would be comfortable making the recommendation. But I do think there's a lot to recommend itself with the idea of having a state-based platform in the long run, and everything to recommend itself about having the flexibility to do these sorts of programs that we all care a lot about in the long run. And maybe eventually we can do them through healthcare.gov. So I'm not necessarily wedded to doing it through the state-based system, but I think our long-term goal should be to give ourselves the flexibility to do those things in one way or another.
Okay, let me ask others to jump in on Pat's question. I'm looking at Shannon because did you raise your hand?
No, I would support that, definitely. So I think it's a way to move in the future, but I don't know if for plan year 18 that's the way to go. So I would definitely support your statement.
Maria and Cindy?
I'm not quite there yet with moving forward. Everybody says healthcare.gov is getting better. If I thought a technology platform would improve health outcomes for various communities, might get me further there, but I haven't heard anything compelling. I think building out there in the future should always be asked. Should we do our own platform? But I'm just not ready.
I'm definitely open to revisiting. I'm not sure that a state-based exchange will do the important things that folks like Joe and others talked about. There may be some better vehicles for getting there. But I'm open to looking in the future.
And Maria, just because you're on the phone, I want to call your name out and make sure you have a chance to weigh in.
Thank you. I'm still sticking to my position just based on experience. And again, I think our focus needs to be on other things, not necessarily the technology right now. And just kind of to make sure we're using the correct term, it's not about having a state-based exchange. We have a state-based exchange, and we'll continue. It's about the state-based platform and what we're using for enrollment. Is that correct?
Yeah, thanks for that. I was going to bring that very same point up.
Very great. So did that answer your question?
I'm afraid so.
You asked it in a negative, and I think you were hoping for a different answer.
Clearly.
Yeah, I just have a quick question from a comment that was made with respect to health records. And I guess I had no notion that the work we were doing dealt with that. And I just want to make sure I'm...
It doesn't, but just in futuristic thinking from a funding perspective, I know that healthcare providers would love some kind of instant access to patients' medical histories, medications that they're taking. You get those traumas in that aren't talking to their family, and there's other situations that would be very beneficial in. We're already entering information on immunizations statewide.
Okay, I just needed to get it clear in my mind because that was
me from a clinic.
That was something I hadn't even considered. Thank you.
And there's some other initiatives out there, the e-platform and some other things you may be aware of that we should.
We're already are reporting that.
Yeah, terrific. That go to that goal. So Pat, I'm hearing you certainly don't have a mandate to tell the legislature we want to move aggressively to a state platform. I don't think there's a majority here for that. I think a message that I'm getting is that this group is going to continue to look at what a technology platform switch would bring to the state, if not for 2018, then for beyond. And maybe that's something that we need to actually dive into deeper based on today's discussion. That final point from Maria was a powerful one, which is it is a technology platform. We really understand fully what we can do with our current state-based exchange and what would truly require a change in technology to achieve. I don't understand that, so there may be others as well who don't understand what specifically a technology platform switch would gain us in terms of some of the objectives we've talked about.
Well, thanks, and I think this discussion has been really, really helpful, and it's been a great discussion. I think your original sort of characterization of the three buckets is very useful, and I think likely what we would use to characterize the discussion today at the legislature. Make sure to give full voice to each of those, that there were strong. I mean, if I were sitting here, I'm not sure which bucket I would ultimately end up in, because there are strong reasons for each of those. So I think that's what we'll end up taking the legislature right this month.
And if history is any guide, legislators themselves will have an opinion.
This is Jim, just with one comment, and that is, no one's talked about how in the world the state of Oregon would implement SHOP through healthcare.gov.
Well, Jim, this is Pat. The simplest answer to that would be what still remains available to us is a change in our pricing methodology that would allow us to use the federal platform. And I think the other piece is that the 2-year deferral of the requirement to implement SHOP is CMS telegraphing. They think there may be a significant policy change on that, driven not least by the fact that the very most aggressive states in the implementation of SHOP haven't drawn much business to it, and that would allow us the opportunity to step back and focus on the real underlying goals, which is easy access to meaningful choice for the employees of small businesses, and evaluate whether SHOP as currently defined in federal law is the very best way to do that. I think we've still got some options on the table, but it gives us a little bit more ability to evaluate those.
Jim, does that get to your point? I know as a small business owner, you're keenly focused on SHOP.
That's what I hear in my various trade associations. When is there going to be something for small businesses? And so it sounds like there would. So I guess I haven't heard an answer. So I'm waiting, but I'm sure there's one there. We'll have to see.
It depends on what you mean by something. There is something today in terms of the direct enrollment option. If you mean SHOP with a little trademark symbol after it, meaning the federally defined SHOP, my guess is that's never going to be available unless there's a change in our pricing methodology. And even then, it may be questionable whether that has any value based on other states' experiences. If you can find me a state that has a significant enrollment in SHOP, I'd love to talk about that and see what they're doing. Because everything that I think I understand is that on paper it was a great idea. It appears not to work.
Well, and to add to that, we have not allowed the fact that we don't have a SHOP to stop us from being out and supporting small businesses every day. I mean, almost everything we do intentionally is to support small businesses through our COBRA program or Agent Storefront program, who provide insurance for their employees, but there's also a lot of small businesses who don't provide insurance but want help with communicating with their employees about insurance options. And so it's a huge goal for us, and we've not let grass run or effort related to that, and we've made huge inroads in that topic. So we can do both things. I think we can
continue to explore what some actual technology solutions are for small business, while also continuing to make helping and supporting small businesses a big effort.
Jesse, can I jump in again real fast?
Yes.
I was just going to say, I feel like we really need to take on this shop discussion as a pretty urgent priority for this group going forward and for the marketplace, because I feel like the difference, and maybe others will disagree with me about this, but I feel like the difference between the platform discussion with the individual market and with shop is that we do actually have something that is working for individual market enrollment right now, and it doesn't do all the things we would want it to do, and I have some complaints about it, but with shop, I mean, there is the kind of workaround that's developed, but I haven't heard anyone say that that's working especially well, and I think, Pat, your point is well taken, that shop itself is not necessarily working particularly well in other states, but I think we really owe it to Oregon's small business community to figure out something that will work, because it's been years of promises at this point, and we still have very little to show for it.
Really agree.
Yeah.
Dan, I know you've been out of time. Do you want me to take 2 minutes to talk quickly about the broader insurance market?
I do. Let me just ask, we're right at time. I think it is important that we understand the context of the broader insurance market. Pat's going to do that for us. That's been in the news as well. But any closing thoughts or comments? I'm always available. Jesse, as vice chair, is always available. Pat and Barry are always available. So we can, kind of like they say on public broadcasts, we'll keep the conversation going between shows. And this is a helpful discussion that I think will set a nice foundation for us in the coming months and even years as we talk about this. And I really appreciate the fact that everybody here was fully engaged. And we heard a lot of different perspectives, and I can't tell you how important it is to hear different perspectives. And we had really good, respectful conversations. So, any closing thoughts? Otherwise, we'll go straight to Pat, and you can bring. Is there any good news to bring us from the larger discussion, or is it all double digits?
Well, when you put it that way, three things about the rate filings which came into us last Monday at midnight. And I'll talk about price, churn, and geography. Price, I think you've probably seen the top line story that the rate increases we were asked for ranged with a couple of outliers that are a little bit weird, from about 15% to in excess of 30%. The largest carriers were grouped right around 30%. So that's kind of the state of play. It's important to keep in mind when you see these numbers that this is before people go through open enrollment and shop and make decisions. So last year we had a pretty broad range of significant increases, and the actual increase as paid by people after they had gone out and shopped was about 11%. Not insignificant, but not 25%, which I think was on average if everyone stayed with their plan and all those increases happened in numbers. So that's important context for seeing that 15 to 30% range. The second is churn. Now this is all before any of these rates have been analyzed or approved, or the public hearing process that goes on. There's a several months body of work before these rates get finalized. But if they were finalized at the as approved levels, I think we would again see changes in placement in terms of relative pricing of various carriers, and that's becoming an increasing concern. A market where this year it's some other carriers turn to be the largest carrier, and then they end up pricing themselves differently next year. Next year it's somebody else's turn, is not a very functional market, not least because it makes population health investments almost impossible to be able to rationally do. And that really is about the actual health of people, not their health care and bending the curve and all those kinds of issues. So we're concerned about that issue. And then probably the thing that'll get the most news, I already got some a little bit late last week, and it'll get some more this week, is the geographical implications of this. There are 9 counties that will have 2 insurers on the marketplace and 2 more off the marketplace. The on-marketplace are the same for all of the counties. It's Bridgespan and the co-op, which raises some issues about company size, brand familiarity, those kinds of things. And then 2 carriers off the marketplace, HealthNet and Regents. The counties are uniformly eastern counties: Umatilla, Union, Wallowa, Malheur, Grant, Harney, Baker, Lake, and Curry. Now, the interesting thing is we've done some very, very quick looking at other very rural counties around the country, and I don't want to minimize the impact of 2 on, 4 total, but many rural western counties actually are frequently facing just a single carrier of any kind. So we do still have some meaningful competition here, but that's a concern. There are another 14 counties that only add one more provider to that mix. You would add Providence to the list in Lane, Lincoln, Tillamook, Morrow, Gillum, Wheeler, and Sherman counties. You'd add Pacific Source to Crook, Jefferson, and Deschutes. You'd add Moda in Jackson and Coos County. You'd add a trio to Douglas and part of Klamath County. So there is some geographic stuff going on that's driven by things that vary from carrier to carrier, but I think it's available risk pools, and you'll find more carriers the more vigorous the competition among providers, especially hospitals, is. That's kind of a quick 3-part snapshot of what's going on in the overall marketplace.
Yeah, one thing that doesn't get out there much is that that's the individual side. Small group increases were actually, I think they're pretty small.
Yeah, that's a great point. The stability of the small group, yeah, it ranges from a handful, well, not a handful, a good chunk with decreases in rates and a good chunk with increases in rates, and the increases are quite a bit smaller than they are in the individual market. And so you're right. We had hoped to not see quite as much price volatility because the prices had about converged now between with this year's prices between the individual and small group markets. And so we do really sort of have this interesting patchwork of populations. You know, companies on the Medicaid side making lots of money on serving very poor people. Companies in the tax credit eligible QHP losing money on serving less poor people. Hospitals currently making a fair amount of money. It's a small group being reasonably profitable business. It's sort of all over the board, and trying to figure out how to I don't know what the right word is, even harmonize that, or figure out how to spread that risk differently, I think is a big mission that we're going to need to focus on over the next.
And we want this advisory committee to get to that, you know, obviously not for a while, but thinking, and I love that, you know, the range you just gave us, how do we harmonize that and create a sustainable market so that we have choice in every community. Right?
A question related to small group, has that market declined?
Not significantly though, right?
30% last couple of years.
Yeah, it's a good size. And what you found is that you've got less small group, more individual, and on balance, more of the two combined.
Yeah, yeah. And I think that paints a little different picture than just saying.
No, that's right. And a lot of folks who are in that small group market, I believe, on balance as individuals, are probably better off in the individual market where they have access to tax credits and the sort of the net price and richness of benefits that they have available to them in that environment versus what a small business may be able to offer them in that environment.
I know some people have a drive ahead of them, so I want to get ready to cut people loose, and I appreciate people coming all the way out to Pendleton for this discussion. I didn't want to cut you off, though. One last comment.
Just a related comment. It's just kind of in left field, but I was talking to my car insurance carrier about car insurance rates going up and up. And one of the things he said it's not the cars are safer, blah, 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 blah. It is health care costs. Yeah, auto insurance is going up dramatically because of health care costs. And that's one of the reasons transparency is so important to me, because without the consumer understanding the cost, the actual cost of their health care, not insurance or copay or whatever, it covers a broader spectrum.
Although, interestingly, workers' compensation rates are continuing to go down because there's not significant health care cost inflation.
Interesting.
Yeah.
So it just covers other areas.
One thing that Oregon's credited around transparency that sometimes gets lost is that one of the reasons Oregon's getting national press right now is because I think only Oregon and Virginia's rates are public. Right. When we push the button in Oregon, those rates are out there.
And we go first.
And you go first. So, so it makes that available to everybody right away. When we filed rates in Idaho at the same time, and those rates probably won't be known in the market till almost open enrollment.
You may not understand this, but what Ken's talking about too is an online filing system where the press isn't waiting for us to do an analysis and a press release and a bunch of digestion. They're able to sit there on their computer as they do and see the filings as they come in and look at the same stuff we look at, and anybody in the public can as well.
Yeah. Not to clarify, I think that there's transparency at that level. It's just,
She means at the provider level.
Right.
We'd all be eager to see that.
Yeah.
So with that, let me bring us to a close. We're a little bit over time, but I appreciate people's indulgence. This was a great discussion, and I think, Barry and Pat, I certainly hope we've given you and the team some good feedback, and hopefully that'll help shape our discussions in the coming months. Where's our next meeting?
June in Eugene, I believe. And I have already heard a couple of, sounds like shop really should be on the agenda, and it sounds like transparency as an issue would be a really great topic. So we never have a hard time coming up with agenda for these. I'm finding.
All right, everybody travel safely. Thank you so much.
Thank you.
Thanks.
A quick question, just a really quick process question. This is Jesse. Do we know for certain that there are no public comments?
We are quite certain of that.
Nobody signed up. Nobody signed up, and nobody raised their hand on the call-in to speak.
Okay, I just want to make sure that we're making time for that if there's anyone interested.
Jesse, on that, there were minutes in there. If people have comments or suggestions, we didn't do a formal approval, but that doesn't mean that if we got something wrong in the minutes, let us know. So
send them to me, please.
Yeah, send them to Barry and let us know, and we'll try and move that to the front of the agenda next time so we ask for help. Let's go. Yep.